Okay, good morning, everyone, and welcome to PerfWeb 25 Part 2. Renal function, AKI, and fluid balance are going to be our topics this morning. Let me very quickly get through the obligatory things that we have to do. We're on all of the social media, as you can see here. I need you to please, on the YouTube, become a subscriber. That's how you do it. Check it out. It's showing you. Subscribe and click the notification icon so that you will get notifications of that. Also want to remind you about our program next month. The New Orleans Conference online edition. That's going to be good for 10.6, Category 1 CEU by the ABCP. And I'll make an announcement, too, before we end the show as well. So remind me about that again. Like us, please, on Facebook. And please, please, please follow us on the Twitter. Then we also have a phone line that you can call in. And there it is right there, and the trusty phone is right here. I can answer it. You can be live on the air. And today we're giving away a special prize if you call in and ask a question. Not going to tell you what the special prize is until you call in, but you will get a special prize. It could be one of these stylish PerfWeb cups. Could be, and this isn't my PerfWeb Yeti, but we have PerfWeb Yetis. We have visits with John. We have babysitting for men. We have crawfish boils. We have a lot of fun. So please, please, please do those things for me. It's very important. I think we're over 800 subscribers now on our YouTube channel, and we need to get to 1,000. It's really important. Please subscribe to our YouTube channel. It's very easy to do. Get a Gmail account, go to our YouTube channel, click subscribe, and then click the notification buttons. Even if you don't want to click the notification buttons, click the subscribe. It's really important to us. Okay, our topics today are organ crosstalk, fluid balance, and fluid overload, and how that is deadly. You're following it up with your last talk on
ECMO.
That's right, ECMO and the contribution of ECMO to acute kidney injury. Exactly. Thank you very much. I appreciate that. So you remember John Ingram from last night? He's down at Florida. I've been a perfusionist for many, many years, down at Florida Advent Hospital now with an 8-bed ECMO unit that is over full, so they have other units having to take the patients, opening up a 32-bed dedicated ECMO ADVAD ICU. The hospital at Florida Advent in Orlando is unbelievably huge. I've never seen anything that big in a single place before in my life. I thought I've seen big hospitals. That place is enormous, and it's beautiful. I mean, Disney was involved in some of the donations and the units and stuff. And it's they have a children's hospital, very, very, very patient-centered. It looks like. And very calming environment. I was really impressed by their hospital. I really was. And then next to John, you remember Tammy from previous programs, Tammy Lee Sparacino. Tammy is a graduate from the Texas Heart Institute. I believe it was either 1987 or 2003, one or the other. And Tammy works with us here in Houston. And she spent a lot of her career at Memorial Hermann, in the Memorial Hermann system, or Memorial City. A lot of experience with perfusion and ECMO. And next to her is my adopted son, Min Tran. He's a graduate of Texas Heart Institute, 2013?
2008.
2008, that's right. And Min used to work down at Methodist and TMC, did a whole bunch of ECMO and VADs and very high acuity patients. And now today he works up here with us in the northern Houston area, and still seeing a whole lot of ECMO, even though he left the ECMO center for another ECMO center that's out in the community, which I think we're seeing more of the ECMO shifting out to the communities. Okay, so I think that's the end of my opening remarks. Is there anything that I forgot? Nope. Okay. So I'm going to just let this go right over to John and let him start his discussion on organ crosstalk, which I think is a fascinating conversation and something that I think most of us really don't spend a lot of time thinking about and how everything interplays with each other, all these organs, and how important it is to keep all of them in a normal physiologic state so you don't have these other unintended consequences. It's never just a single thing.
Right, and that's where you get this title, Organ Crosstalk. And I'm glad you asked me to do this because I didn't know all that much about it myself, and it kind of forced me to look into this and research it. So, title of this is Organ Crosstalk, and I don't have any disclosures on this, but let's talk about what is organ crosstalk. And the background of it is that if you go back over 70 years, it became apparent that acute kidney injury rarely occurred in isolation. And since the 1950s, they noticed that there was abnormal chest x-rays that were observed frequently as a frequent occurrence whenever somebody had kidney failure. It seemed they also had abnormal pulmonary conditions as well. And so it was these observations that led to the suspicion that there was some type of organ crosstalk occurring here. Also, though, the high rate of mortality seen in acute kidney injury is a result of some underlying systemic response that often leads to multiple organ failures. So based on these facts, there seems to be something below the surface, so to speak, that's going on. And just to have an isolated organ suffer injury, you would think you could keep it to that, and it tends to just completely spread to the other ones. And so what's the definition of organ crosstalk? Well, clinical studies have demonstrated the interactions between the injured kidney and distant organs. There's complex mechanisms of crosstalk have been identified between the injured kidneys and remote organs such as the lungs, liver, heart, gut, brain, and even the hematologic system. So the kidney, as it turns out, is the center of almost the overwhelming majority of organ crosstalk is generated right through the center of it, seems to be the kidney. And if you have cardiorenal crosstalk, you can have renal pulmonary crosstalk, you can have neurorenal, hepatorenal, you can also have immunorenal, where the kidneys directly affect the immune system, and at the bottom you can just have that it affects the hematological system. And you can have any combination of these. So injury to one organ may result in injury to other organs. It doesn't have to go through the kidney, but the kidney is overwhelmingly the center of where most of this occurs. So you can have any interaction between any other organ. And as you can see, the kidney is usually the heart of where it starts and where it propagates from. But you can have other organ crosstalks. So organ crosstalk is most commonly initiated back to ischemic acute injury again, Joe. Renal ischemia reperfusion injury occurs in shock, sepsis, organ transplantation, vascular surgery, and we know it occurs in cardiac surgery and ECMO and any situation where you could have a hypoxic event followed by reperfusion. So ischemic reperfusion injury in the kidney propagates a cascade of vascular inflammatory responses. This is really a take-home slide for anybody who likes to take notes. This is probably one of the most important slides going to be on this talk, because this inflammatory response activates endothelial cell activation. Most people don't think about it on the endothelial cell level, but if you think about what happens here and you realize what happens here is that the endothelial cells become into a pro-inflammatory and a pro-coagulant state of the endothelium, and it's due to its interaction with the white blood cells. So then you have leukocyte adhesion and entrapment. Now this is a hallmark of the inflammatory process, whereby adhesion proteins, something called selectins and integrins, we're going to talk about that, cause the white blood cells to actually adhere to the endothelium. Imagine that. Your immune system has now begun to attack your own layer, your own endothelial layer. And then you result in compromised microvascular blood flow. It's a result of the endothelium becoming inflamed and narrowed by the white blood cells' adherence. Okay? So inflammation in the post-ischemic kidney triggers leukocyte adhesion molecules, something called integrins and selectins, selectins. Integrins are cell membrane receptors that facilitate this adhesion. They become activated. Selectins help coordinate and promote this adhesion of the white blood cells and the platelets in immune responses. So then you have toll-like receptors. These are cell membrane receptors that are on macrophages as part of the immune system, which activate immune cell responses. Then you have transcription factors. These are proteins that are actually involved in transcribing the DNA into RNA. A lot of people don't think about the inflammatory response having anything to do with our DNA or RNA, but actually it's at the heart of it. Because at the cellular level, the very basis of inflammation is the deployment of complex gene expression programs that include hundreds of genes and are activated within minutes after a primary stimulus. In other words, there's an expression of multiple genes that upregulates the cytokines, chemokines, adhesion molecules, receptors, and inflammatory enzymes. Then you have your pro-inflammatory cytokines. This is a signaling molecules that is excreted from the immune cells and they further promote inflammation. So all of these things then travel from that organ into the bloodstream. They go to remote organs where genomic markers of injury are upregulated in that particular organ and phenotypic injury occurs. Phenotypic being now injury specific to that organ then begins to occur. So they've tried to treat this, and what they discovered was when they did selective inhibition of cytokines and adhesion molecules, such as the big one we talk about a lot, tumor necrosis factor A, and intracellular adhesion molecule ICAM1, when they've tried to inhibit these, it failed to demonstrate any global attenuation of both the local and remote organ injury during experimental models of ischemic AKI. So this unsuccessful effort to ameliorate the multi-organ failure with specific anti-inflammatory therapeutics highlights the complexity of this systemic response to kidney injury. So let's look at the complexity of organ crosstalk. Okay, so again, you have the kidney that's at the center of it, and you have different pathophysiologic responses to AKI in each of the remote organs. That's the unique thing, that each organ is actually being affected by different inflammatory responses and mediators. So there's multiple inflammatory pathways that are activated in each organ that represent a unique response to the ischemic AKI. AKI induces remote organ injury in the heart, brain, lungs, liver, and gut, involving multiple different inflammatory pathways. And this happens via pro-inflammatory mediators, innate and adaptive immunity. You know, you have your immunity that you're born with, but then as you live your life and you're exposed to things, now you have your adaptive immunity. This also plays a role in your immune response. Then you have cellular apoptosis. Is that how you say that? Mm-hmm. And this is pre-programmed cell death that your cells automatically have, which are a controlled system of cell death, so that cells just don't die and release their toxins into the bloodstream. It's actually controlled where this doesn't happen. Well, when this spins out of control and you have this cellular death that's going on and there's inflammatory responses, now you have the toxins that are released into the system. Mm-hmm. You then also have a whole physiologic derangement. This is a system-wide derangement of your organs that are affected in this response. And then finally, you have the genomic changes, which are the DNA and RNA responses that I was talking about earlier. So we're going to discuss kidney crosstalk combinations. We're going to discuss the kidney-lung crosstalk. We're going to discuss kidney cardiac, kidney CNS or brain, kidney and liver, and we're going to talk about kidney intestine. So first of all, the kidney-lung crosstalk. So it's a pathological crosstalk between the kidney and the lung, and how AKI leads to ALI, acute lung injury. So if you look there in the lower, like, what is that, 7 o'clock on the clock there, acute kidney injury starts, and it releases oxidative stress, cytokines, chemokines, activated leukocytes, and uremic toxins, right? So then it goes up, and those things affect the lung. And then you have alveolar cell apoptosis, fluid pressure is changed. Then you have a dysregulation of the sodium and water channels. At the alveolar level, if you have a dysregulation of the sodium and water channels, your lung takes on fluid. you begin to have pulmonary edema right away. So this relieves also this inflammatory markers by the kidney, leads to an increased vascular permeability, again, leading to pulmonary edema. So now you have acute lung injury. The acute lung injury then has inflammatory responses of its own. Okay, but the first thing that happens is the lung doesn't function very well. You become hypoxic. You become hypercapnic. You begin to need higher PEEPs from the ventilator. Then you have barotrauma, possibly. This then, these underlying mechanisms, okay, because of the hypoxia, leads back to decreased renal perfusion, blood gas deterioration, and inflammatory markers as well, which now are injuring the kidney back all over again. So these two are just bouncing back and forth and aggravating each other, just these two alone. This is the most common. AKI induces pathophysiologic effects on the lung via the cellular and soluble mediators. The injured lung, in turn, exacerbates kidney dysfunction through metabolic and biochemical derangements. So the kidney-lung crosstalk. Now, when you talk about ALI, acute lung injury, most of the time it's defined as a ratio of the PaO2 over the FiO2 ratio being less than 300. What does that mean? If you look at the denominator, I put 1.0 there. That's, let's say you're on 100% oxygen on the end ventilator, but your PaO2 is only 80. So the ratio is 80, so you're well below 300. So any combination of FiO2 giving you a result of PaO2 that is less than 300, okay, is defined as acute lung injury as long as it's combined with a chest x-ray that shows bilateral infiltrates not caused by elevated cardiac filling pressures, okay? Just to give you an idea what most people refer to as ALI. So in multi-organ failure, acute kidney injury and acute lung injury occur more frequently together than any other combination of organ systems, and the mortality of nearly 80%. So the ALI, the acute lung injury, is due to volume overload, leukocyte trafficking, uremic toxins, and oxidative stress. The ischemic acute injury results in decreased alveolar fluid in the lungs, clearance via the downregulation of pulmonary epithelial salt and water transporters. These include the epithelial sodium channels, the sodium potassium, ATPase, and the aquaporins, which are water channels. All of these happening in the lung, most of them in the alveolar level, all lead to an imbalance of keeping the lung dry. And all of these are dysregulated, you become pulmonary edema. This results in increased microvascular permeability, pulmonary edema, frequently encountered in the setting of ischemic AKI and multi-organ failure. So here, acute kidney injury leads to lung injury and inflammation, and in turn, the lung injury leads to pulmonary vascular permeability, erythrocyte sludging in the lung capillaries, and interstitial edema, focal alveolar hemorrhage. So think about this for a minute. You have erythrocyte sludging in the capillaries of the lung. You have focal alveolar hemorrhage. What is it you always find most of the time when you do a bronch? You find blood clots. Your lung injury, most of the time, is going to have sludging of the erythrocytes and bleeding inside the alveolar. Inflammatory cell infiltration. So the resulting hypoxemia and hypercapnia from the acute lung injury are then made worse by mechanical ventilation. Paradoxically, the high PEEP creates an increased renal venous pressure, right, which now diminishes renal blood flow and function as well. So in addition to the inflammatory communications, you now have a hemodynamic implication where you have to increase the PEEP. That increases your IVC blood pressure, which increases your renal vein blood pressure. Anytime you increase your blood pressure in the renal vein, it's detrimental to the kidney, and it doesn't take much.
On the outflow.
On the outflow, right, coming out of the kidney. So you're back stuffing, right? So now let's talk about kidney and cardiac crosstalk. Mechanisms of cardiac injury during ischemic AKI include cardiac myocyte apoptosis. So here you have the myocytes of the cardiac cells, unregulated cell death. You have neutrophil infiltration, which we see this in almost all inflammatory responses. They've been attributed to increased cardiac and systemic TNFA again. You have your interleukins. Interleukin 1, now when we talked about this yesterday and we'll probably talk about today, that the hemoconcentrator removes a lot of these inflammatories. We talk about interleukin 1, 6, 8. Those are not isolated single entities. Interleukin-1 is actually a group of 11 cytokines that play a central role in the regulation of immune and inflammatory responses to infections and sterile insults. Then you have the ICAM-1, intercellular adhesion molecule. It's a ligand for integrin and causes the leukocytes to bind to the endothelial cells again and then transmigrate into the tissues. So in experimental models, you take animals and you isolate and clamp off the renal artery perfusion, give them ischemic AKI. Within a short period of time, it begins to demonstrate left ventricular dilatation.
And increased lung water.
Well, we were talking about cardiac, right? So this is interesting because if you take, let's say, an animal and you just simply open them up, put them under anesthesia, and you give them ischemic AKI, you begin to see deleterious effects in the cardiac function. Their heart was normal. You then see increased left ventricular end diastolic and systolic diameters, increased relaxation time, which is a fancy way of saying, you know, you're dilating. Decreased ejection fraction. So now let's talk about kidney CNS crosstalk with the brain. The effects of ischemic AKI on the central nervous system are evident clinically when mental status changes develop. So here again you have somebody who just experienced AKI. And they begin to deteriorate their central nervous system. So encephalopathy caused by uremic toxins and inflammatory mediators include KC, which is a cytokine, GCSF, granulocyte colony stimulation factor, glial fibrillary acidic protein, and neutrophils, all these things that most of us aren't too familiar with. You then have an increase of chemokines resulting in increased vascular permeability in the brain. You have cell-mediated pro-inflammatory response with an activation of microglial cells. These are brain macrophages during ischemic AKI. This is what's going on in the brain. This may result in an alteration of the blood-brain barrier, right? So when you do renal replacement therapy on these patients, it fails to fully correct this CNS manifestation of renal failure. Why? Because just aiding the kidney in its functions, the kidney is failing, you're going to come in with renal replacement therapy and aid the removal of your urea and so on. It's not as simple as that.
Now,
you have all of these inflammatories.
Before you say that, the renal replacement therapy, are you talking about intermittent dialysis, or are you referring to continuous therapy? Which of the renal replacements are you referring to?
Well, usually the intermittent in this case, because
I think that is what you're referring to.
What they were trying to do was say, well, we have a failing kidney. Well, why don't we just go in and help the kidney out, and all this will subside.
Right.
That failed to correct the problem because you have all of these underlying problems that don't just have to do with the increased level of urea and so on that the kidney's now failing to remove. In kidney-liver crosstalk, you have ischemic AKI has been shown to incite oxidative stress, inflammation, apoptosis again, and tissue damage in the hepatocytes. Oxidative stress during ischemic AKI causes hepatic lipid peroxidation to increase while antioxidant agents decrease. Pro-inflammatory cytokine, tissue necrotic factor A expression and hepatic cellular apoptosis is evident again during ischemic AKI. So crosstalk stimulates hepatic stellate cells, which exacerbates leukocyte trafficking and a secretion of chemokines. What about the kidney and the intestine? While the kidney is the engine of the organ crosstalk, it is actually the gut that you can call the driver of multi-organ failure because its ability to amplify the systemic inflammatory response in the setting of shock and gut hyperperfusion. These mechanisms include increased intestinal permeability, now interactions between the host and bacterial pathogens. Because of the gut, it's unique in that ability to do that, so it's particularly powerful negative in multi-organ failure promotion. So propagation of toxins to distant organs via the lymphatic system. So in conclusion, AKI is a frequent complication amongst hospitalized patients with grave implications in the setting of multi-organ failure. Ischemic AKI initiates this cascade of pro-inflammatory pathways, and through the release of soluble mediators and activation of host innate and adaptive immune systems, facilitates organ crosstalk and subsequently remote organ injury. So as our understanding of post-ischemic kidney's role in mediating organ crosstalk continues to evolve, it's hoped that the therapeutic treatments we can develop for this devastating complication will emerge. I think that's all I have.
Wow. Okay. Very good. I'll give you an applause on that one. A couple of questions. Joe Bulaki, I hope I'm saying that right. Anil. He's a perfusionist in Mauritius. I don't know where that is. We'll figure it out. But he's asking a number of questions. He's like, what is the value of O2 delivery we need? And I'm assuming he means on bypass. Is it 272, 262, or 230 index per minute per millimeter squared? That was one question. Anybody on the panel can answer this. But he also is asking, what is the hemoglobin level we should keep to prevent AKI? And if we have to add blood to attain the hemoglobin level, are we doing good? Well, I mean, the simple answer to that is the hemoglobin level you need depends on how much O2 you're delivering. So that kind of goes back to the first question. And two, you're never doing good giving blood. Sometimes you have to. You're damned if you do. You're damned if you don't, Joe. But you want to just start down there and kind of come back this way with any comments on those two questions?
I mean, I think, anytime, you're on bypass and you always want to try to maintain a decent, H&H just to make sure you have, good, oxygen carrying capacity for your hemoglobin. I mean, I know you're on bypass and depending on if you're cooling the patient, depending on if you're more normothermic or, you're cooling to like 28 degrees, then maybe you might be able to adjust your PO2 and get away with running a low hemoglobin, and then when you come off, see if you can give back a cell saver if you want to, be smart about blood conservation and not having to transfuse, depending on how critical that number is.
Oh, I agree with that too. I think blood is always a last resort. I think this goes back to the talks we were having last night, or y'all were having last night, about ultrafiltration. I think it's a real tool that we can try to use to help us prevent giving blood. I mean, of course, sometimes you have to. Sometimes the patient's, just hemodynamically unstable because their hemoglobin's too low. But I think really that should be our very last resort.
I would agree with that. John, you want to tackle Joe's
it
questions?
sounds like he might have watched PerfWeb 23 because when we did that one, we referred to those exact three papers. There's three papers on delivery of oxygen that give those exact parameters or levels that they were looking at: 230, 272, and 262. So there's still a lot of research that needs to be done to figure out what is the critical level that we need to stay above. We don't know that, but the general accepted right now seems to be the 272, which is a paper by Renuzzi out of Italy that's done the most work on this. But so I would suggest that if you're monitoring DO2, try to keep it 272 and above. As far as the hemoglobin goes, when you only look at hemoglobin, you're not seeing the whole picture because you need to look at delivery of oxygen.
Right.
You don't, the minimum the minimum hemoglobin level depends on how much you're flowing. Look at the delivery of oxygen formula. Hemoglobin is only one of 4 parameters that are going to affect it up or down.
Right.
If you have a lower hemoglobin, you're going to have to flow more. If you have a higher hemoglobin, your delivery of oxygen is going to be greater of what you're carrying. You can flow less. So I don't know that there's a golden rule when it comes to delivery of oxygen and hemoglobin. You need to be delivering enough oxygen. If you're not doing that, you need to up your 4 parameters: blood flow, hemoglobin, PO2, and saturation.
Well, yeah. I mean, that's a very good point, and I think that we can kind of take that down another rabbit hole and say that if you could flow enough, essentially, you could have a hemoglobin of 5. The problem with that, though, is what other since we know hemoglobin is our strongest buffer in the blood, it's a great buffer. Without it, we're going to be becoming more acidemic just from the anemia, not necessarily from hypoperfusion, but that non-viscous state more and more. How does that affect things? Are we going to have can you flow enough with a hemoglobin of 5 to get away with it?
Well, nothing lives in a bubble, right? I mean, so
Yeah.
you have to look at if you're going to an extreme on something, you're probably negatively affecting something else.
Agreed.
Which you begin
Yes.
to do.
And you have to sit there and think about that. Like, what's the
Yeah.
consequence of this?
I mean, you couldn't have a hemoglobin of 1 and be flowing 20 liters a minute. Theoretically, maybe your delivery of oxygen says it's okay, but you have to look at nothing just in a bubble by itself. So you have to look at, but we don't, this is a real good area. The delivery of oxygen, especially in regard to how it affects the kidney, is a whole area that we've scratched the surface on, and some people have done a lot of work, so we do know a lot, but I think we really need to have that as a focus, and if we're looking at that in the future as perfusionists.
Well, I want to ask you a question, if I can, regarding the patient with the cardiorenal syndrome that you were talking about, and how correcting the AKI did not improve anything with the heart. And of course, that is a complex relationship, which I think you very eloquently described in your slides and with your work that you did on that. But they saw no improvement with RRT, and I sort of stopped you right there to get from you, are we talking renal replacement therapy as intermittent dialysis, which is only diffusive clearance, or are we talking about CVVH, where you're removing, especially higher doses, inflammatory mediators and so forth? Because there is a big difference between IHD and continuous therapies, and diffusive therapy versus convective therapy. So I'm I'm curious what your thoughts are on that.
I think
and whether if they'd have done that type, it would have made a difference that you saw improvement.
I mean, this is really sort of an overview. That's a good question. I really wouldn't say I know the answer to that, but I think you're talking about when this all initially was being looked at some years back, and I don't know the specifics of what they did on that. Yeah, it'd be a good question to look into. I don't know the answer to that. Somebody else out there might know something more about that. But now that we have so many elaborate ways of doing RRT, you may be able to hone in on some benefit of the crosstalk aspect of it. I don't know the answer to that, actually.
Man, I had a quick question for you before. I'm going to go ahead and get my talk out of the way. But when you do your hyperkalemia cases, how many liters of ultrafiltrate do you go through to get your potassium cleared, plus or minus?
I mean, we probably go anywhere from, it could be 8 to 12 liters. 8 to 12 liters.
8 to 12?
8 to 12.
Or you think I've done 20. I mean, 8 to 12 would only be 2 of those replacement bags, which are 5 liters each.
Well, we've gone through 5 bags.
5 bags, so that'd be 25 liters.
20. So it'd be, on the highest case, I've done about 25 bags. I mean,
about 25, okay,
yeah.
5 bags. So 25. So
I
somewhere
probably
between,
more within 12 to 15. And
depending on how much potassium
Exactly.
you gave and
How high
whether they're
potassium.
making urine and they're losing a lot of potassium, whatever. Okay, so just another real quick question before I get started. On those patients that you've done with the very high volume CVVH to remove the potassium like that, and we're talking about continuous ultrafiltration where you're replacing it with a solution. We're not talking about dehydrating the patient. This is kind of a zero balance, Z-buff, I guess we would call it, right? How many have those patients done?
They've done well.
Has any of them had any issues, especially associated with, failed kidneys in the ICU?
No, kidneys returned fine. Patients did well. Hearts, came back. I mean, depending on how high you get the potassium, sometimes it takes a little time to let the heart reperfuse.
Well, it never gets ischemic.
Exactly, it never gets ischemic. Yeah.
You just have to get the potassium
Exactly,
out.
get the potassium out. Basically, that's the main thing. And sometimes, depending on every patient is different. Depending on what you need to get the potassium at. But I mean, we've gotten the potassium, up pretty high. I mean, so it's just a matter of giving time to get it off and timing about when you start actually pulling off, because then that takes time to pull off too.
Have you done any of the hyperkalemia cases?
I haven't. Actually, I have a question for you. So, for those of us who aren't familiar with that, how high are you getting the potassium?
They can be as high as like greater than 9. I mean, we send it to the lab.
No, they get as high as 18.
18, yeah.
18. Yeah,
But,
sometimes.
Well,
if they're-
when we're coming off, it'll be.
Yeah.
We've came off before at like 6, 6.5, 7. But then, given medication and Lasix and whatnot, the patient usually gets it off. But you're right. But it'll be. I mean, the lab will send. I mean, our iStat would only read greater than
9.
Yeah, greater than 9.
Right, but we send it to the
Yeah, we
lab.
send it to the lab.
But you just said something, and I'm glad you said it finally, because I'm going to get John looped back into this, where then I'm eventually going to get to my talk. But he said he came off the bypass with a potassium of 6 and sometimes 7, and because it's on its way down, he has no problem with it at all. Tell him your story about what you were told.
Yeah, I mean, in the last, I don't know how many years, I've seen this alongside the trend that the hemoconcentrator is somehow causing kidney damage. I've also heard this almost like a real paranoia about coming off pump with potassiums, even as high as 5.0 or 5.5. Just wait, refuse to come off. You have to get it down. I've seen this a lot in my travels. I'm not sure where it came from or if it's valid, and maybe I'm wrong, but I know that for many, many years, 70s, 80s, 90s, even early 2000s, people were using a lot of straight Pledgisol. In fact, it's still out there. So you had to give a lot of volume and you had to give a lot of potassium.
And it was all crystalloid.
And it's all
wasn't.
so.
We didn't have blood.
The hemoconcentrator in and of itself by itself just doesn't lower potassium. So we always came off with potassiums that were, 5, 5.5, 6, 6.5, even 7. And nobody ever mentioned anything was ill effects about it. And I never really saw any ill effects about it. But now, a lot of places I go, I see people treating potassiums that are 5.0, 5.5, forget about it, won't come off pump, they wait. And I'm just wondering if that should be a topic we can talk about.
I think so, because what I was
I've also had experience.
And I really, maybe I'm a dinosaur. I didn't.
You are.
I am that, but I try to stay alive though. So I don't. I would love to know how these coming off bypass with high potassium, and I've asked cardiac surgeons directly. Do you think coming off bypass with high potassium is benign? And they've always told me yes, it's benign. Everyone I've ever asked said that. But there's a bunch out there that I didn't ask that I don't need to ask because they're yelling and screaming in the OR. We're not coming off pump to get the potassium down to 5, even if it's 5.3 or 5.5. Forget about 6.0 or 6.5. We can talk that a whole other day, I think.
We
It's
will,
a very
but
good
yesterday
topic
you
because
said it was a diuretic.
Right.
And
That's
so
right.
it sounds to me like it'd be a good idea to leave it up there and let the kidney
Actually,
diurese it out itself.
true.
your body is going to, when you return the pulsatile flow, even while you're still on pump, and you begin to fill the heart up a little bit, when the pulsatile flow returns, with the non-pulsatile flow, your sodium-potassium pumps are not working very well. The minute the pulsatile flow begins to return, sodium-potassium pump, every cell in your body, begins to push that potassium back inside the cell. And within 1 to 2 minutes of your pulsatile flow returning, because I've done this many times, sample the patient's blood, you'll find a real serious drop in your potassium. Your body's just not going to let it stay up there. It's just not. But even so, what is the negative effect? It's a negative inotrope, negative chronotrope, really, right? When you're coming off bypass, if that's a negative chronotrope, everything we're doing is a positive inotrope or a positive chronotrope. We might be giving a gram of calcium, or maybe the anesthesiologist giving a gram of calcium. They're on epi, they're on dopamine, they're on. I mean, all of these
cases.
all of these positive inotropes are just way overcompensating for a little bit of an elevated potassium. That's a negative chronotrope. So I've never seen a negative effect from it. Never have. And you're doing this procedure now, and surgeon's probably ready to come off, and you start coming off with higher and higher potassiums. How many times have you done this procedure with the high potassium?
Every case, every case I've done, we've always come off with at least the potassium I've had one case where the potassium actually was below 6, but we just started.
The rest
taking
are all
off
above
early.
6.
Right above 6, but above 6 but below 7. Above 6 but below 7. I mean, we've had normal cases. I mean, even non-hyperkalemia cases where sometimes the potassium gets up too high, but it's a fast case, and then before you know it, you're rewarming,
Right.
and then you get your next gas back, and then the potassium 6.5, you Z-buff a liter or a liter and a half or even 2 liters, depending on how fast your hemoconcentrate is running, and then you might get it down 6.2, 6.1, but you're still going to come off at that. And I think the patients have done pretty well for the most part. You can give diuretics and get the potassium
If you
off.
need to,
If you need
or
to.
it'll just take care of itself. And getting back to that pulsatile flow, the new artificial hearts, all of the new artificial heart technology, and Dr. Frazier, I think, over at CHI, he's Texas Heart Institute, CHI St. Luke's. He's very passionate about this, but they're all, continuous flow pumps. And so that sodium potassium pump mechanism that you're talking about for the intracellular, extracellular shifting of ions and fluids is, I think, adaptive at some point. It's just that when we're doing it, it is such a compressed period of time because there are a lot of patients walking around without a pulse, and they're walking around and doing just fine. So it must be an adaptive process, I think, because
LVAS, heart mate too.
right. His argument, of course, is the capillaries have continuous flow. There's no pulse in the capillary, and it's hard to argue with Dr. Bud Frazier, So it does work. It's just, is it adaptive? I think that's really my question is, because we know that's the case, but for the pump, it's not adaptive because there's no time to adapt. It is just an immediate sort of issue.
So I ran this by our cardiac intensive care nurses. I said, do you guys treat high potassiums? She's like, yeah, our potassium gets, to 5.5, 5.9. We get concerned, and we're concerned about high potassiums, and that's different than bypass, totally different, because on bypass, all the drips are off. Pulsatile flow's off. I mean, you have non-pulsatile flow, you have high potassium possibly because of cardioplasia, but all the drips are off. So your high potassium creeps up. Now we turn all the drips back on, which are positive inotropes, positive chronotropes. The pulsatile flow returns, and the body sees a high potassium, it begins to correct. If you're in the ICU 24, 48 hours, all of your inotropes are going. You have a pulsatile flow, but your potassium's starting to get away from you.
Completely different
So
phenomenon.
a nurse is
right.
not going to sit there and let that trend continue to where it gets to 6 and 6.5 and whatever, and now she has a hard time keeping the heart rate up and the blood pressure up.
Right.
See, we have already gone to the point where we're not treating that at all, and we can easily reverse it with what I just said. She's already treating that, or he or she already doing it, and the potassium's getting away from them.
We can make it better just by simply getting the patient off pump.
Well, it did correct. Have you ever drawn a sample? Next time you have a high potassium, literally wait 2 minutes if you can and get the anesthesiologist to give you a blood sample and check the potassium. 2 minutes of pulsatile flow. I bet you see a huge drop in your potassium. I bet the 6.5 is well below 6, 5.5, 5.6, somewhere in there. I've done it many times, I know.
Some of our pumps, we and for some of the cases we do in the Woodlands, there's a pulsatile flow option on the pump. So I'm curious how effective that is.
None. I'll answer the question for you. 0.
Okay.
There's no pulse pressure.
Right.
It's more of a sine
More of
wave,
an
and it's such a
intermittent-
slow,
More of an intermittent pause.
pretty much. I
Basically.
mean, it's you have to have a pulse pressure
Right.
of at least, I believe it's 30, in order to really have a benefit from pulsatile. From a pulse wave, not to mention the upstroke of that thing is your time matters too. So with normal heart you have big upstroke,
Right.
drop down, big upstroke, drop down. You're
Not much of a pressure gradient.
No,
Yeah.
and it's very slow upstroke and then very slow downstroke. I would say it is only effective at damaging more red blood cells. I don't like doing it. I think it's pointless. Okay, am I ready to do my talk? Okay. Say again?
You ready?
Yeah, I'm ready. Well, we got to answer people's questions, when they have them. I mean, I got to do my job. Okay. Where are we at here? Okay, fluid overload is deadly. Can I have the clicker? Thanks.
Sure.
All right. So, we should avoid the term fluid overload. Here's a diagram of your, basic normal physiology of a 70-kilo man with a body weight of, and you take that, multiply it by 0.06, and you get your total body water content. Now, this is a normal sized person, not obese, not, a normal Texas sized person. This is more of a, I guess this Southern California person, okay. Of that 42 liters, 28 liters of that is intracellular. So the majority of all of the fluid the water that we are made of lives in the intracellular space. You have some in the cell membranes, and then there's approximately 14 liters in the extracellular fluid. Of the extracellular fluid that we have, 10.5 liters of that in this patient is in the interstitial space. And then you have red blood cells, but the plasma and plasma water, everything in the plasma, the liquid portion of our blood, is 3.5 liters. So if you add the red blood cells into that, assuming a hematocrit of, let's say, 45, then, let's see, I'll get it to work eventually. I think we're dying here. Next slide, please. Then our circulating blood volume of that patient is going, oh, here you go, is going to be about 5.2 liters. All right, next slide, please. So how does the water stay where it belongs? Well, it's a balance between osmotic and oncotic forces. Continuous exchange occurs between the intravascular space and the interstitial spaces, and the intracellular compartments and extracellular compartments. Focusing on the intravascular space, however, the total proteins and albumin is 70% of your, basically your 60 plus percent, almost 70% of your total protein content in your blood. That's why it's used as a surrogate for knowing whether your patient is hypo or hyperoncotic. Is the driver, but cellular exchange is largely ionic in the intracellular, extracellular movement of water, and osmotic in that case. But in the extravascular space between the blood vessels and the interstitium, it's predominantly oncotic. Okay, next slide, please.
So, Joe, can I stop you right there?
Yes.
Because you touched on
Here,
something.
okay.
You touched on something that is dear to my heart.
Mm-hmm.
You just, correct me if I'm wrong, you said the albumin, percentage of albumin, protein percentage is about 60 or 70% of the
Yes.
total protein is albumin. So I just want to point out something. When people prime with albumin and they think that they've, cured the problem of diluting out our protein levels, and we basically have become even, you still have 30% of the proteins that you're diluting. Mm-hmm. You're not adding any of those. You're not adding the globulins and all the other ones.
Correct.
So we're doing a lot by doing that. I'm a big
Yes.
advocate of it. But you still have, and this is a good example of it, many other things that are even on pump with albumin, mannitol, plasmolite, with the isonconic electrolytes. We still have things that are trending towards third spacing.
I totally agree.
And that's one of them. 30%
Totally
of the
agree.
proteins, other than albumin, are still being
Yes, and I
diluted
think
down to probably 30-40% lower of what they should be.
That's a very good point. And I think a lot of people don't even realize how what the percentage of albumin is
Right.
for your total protein, and how and I think we grossly underappreciate it. Look, I'll say this as a sort of a precursor to the rest of this discussion. you can take a normal, healthy individual and that, is otherwise healthy, 50-year-old, routine, 2-3 vessel cabbage, whatever, isolated mitral valve or aortic valve or whatever it is, or a healthy, athletic, younger woman who needs something similar, and do just about anything to them, and they're going to be fine. There's those outliers and anomalies and things that happen at curveball. You go, what the heck happened here? But basically, everything we're discussing really comes down to the sicker of our patients, of which, of course, I've been in cardiac. I've been involved in perfusion since 1977, so I'm probably the old man of the sea here. I need my parrot on my shoulder, but back then, we started off with the patients who were just horrible, but it sort of evolved from like the late 70s, mid to late 70s into the early 80s to where, I never did anybody that was over 50 years old or 55 years old. It was cabbage. We did valves and stuff like that, but predominantly our patients were much, much younger and much, much healthier than they are today. Our cases have become much higher acuity. They have many more multi-organ system dysfunctions going on, way more diabetes, way more heart failure, way more anemia, all of the kidney disease, pulmonary disease, whatever you want to, all of this. And their nutrition is worse. Their albumin levels start off way lower. It's a totally different patient. And so these talks, my talk here now, is not about me having to do you, because I could just about do anything. I could probably flow 1.5 liters and you'd probably do okay. But, if you had to do me, you're going to be I want you to flow a little more than that and be a little more stressed. I'd be stressed only because I love you, but if I didn't know you, your case would be a chip shot. I'm going to be a bigger challenge.
In 1985, when I got into this, age 72 and over was contraindication for open heart surgery.
Mm-hmm. Mm-hmm. Yeah, I remember the first
was
time
the
we
life
did I remember the first time we did an octogenarian. It was written up. They had the New York Times, calling, wanting to know about it.
Mm-hmm. I remember very early on, we listed all the indications for cardiac surgery and the contraindications, and one of them was age 72 or older, contraindication for cardiac surgery.
Mm-hmm.
Wow. I think that's changed a bit.
Yeah, just slightly. Okay, so back to my slides. Back, okay. All right, so let's see, here we go. Let's see if it's gonna work. Is it working, fellas? Just go to the next slide for me, please. We're at the very beginning. There we go. So here's an interesting article. How does the water stay where it belongs? Okay, this article here, and I believe it was out of England. It was published in Perfusion. A good article. But in this article, the authors discussed hyperosmolar primes, putting mannitol in the prime, and the concern was that if you create an immediate hyperosmolar state, when you go on pump, that you can cause potentially osmotic demyelination syndrome, and of course we know that's bad. But and I'll say, however, hyperosmolar states are created every day for closed head injuries, for example, by giving the patients massive amounts of mannitol, hypertonic saline. You drive the sodium up to 150, 100, even higher sometimes. And both hypertonic saline and mannitol are used. So very frequently. This reduces the intracellular water. So on a closed head injury, for example, you want to make the intracranial pressure as low as possible. So you give this in order to shrink the brain, basically all of the cells of the brain. And typically, demyelination syndrome occurs when you have a sodium below, I believe it's 120, and you rapidly correct the sodium to get it back up to 138 or 140. I have to say, I think the paper was a provocative paper and thought out well, but I don't necessarily think it is germane to adding mannitol to the pump prime. I don't think, unless you just had 100% mannitol prime with nothing else in it, and maybe threw some hypertonic saline in with it, that you're at a risk of having that problem. I think having a somewhat hyperoncotic, hyperosmotic prime makes sense, because if I have to choose between shifting volume from the interstitial space into the blood vessels and maybe even intracellular to extracellular transiently, I would rather that than shifting it the other direction. I think there's less risk of longer term sequelae associated with that. Next, oh, here we go, I got it. In regards to third spacing from a reduction in oncotic pressure, your plasma refill rate, PRR, is reduced and fluid accumulates in the interstitial space. That's what that is. So there's constantly a shift of volume of water and even plasma or albumin across your cell membranes and your vascular through the capillary system. And it goes out, but there's a pull to bring it all back in, and that's called your plasma refill rate. Albumin, though much maligned for seemingly no good reason, is very, very influential in this. And capillary leak syndrome, because I hear a lot of times, oh, we don't want to give albumin. Look, the patient is very third spaced. They have capillary leak syndrome. Well, capillary leak syndrome is not equal to decreased plasma refill rate secondary to hypoalbuminemia. Capillary leak syndrome is its own process by which, and it's an inflammatory process that causes this to happen, and it's devastating when it does. And in those cases with capillary leak, giving albumin would be the last thing you would want to do, because you give it and it just makes the matter worse because it leaks out. But those patients are in devastating shape, and it really requires a plasma adsorption or plasma purification technique to relieve the severe inflammatory response syndrome. Next slide, please. Go ahead, next slide, right there. So, what does fluid overload look like? Does it look like this? Anybody? Does that look like fluid overload? It does? Okay, next slide. No, wrong. Next slide. Does that look like fluid overload? If you look at that, you can see that the heart muscle, it looks like it's stuffed, but it's swollen. It's almost, again, we've seen this before with very, very sick hearts. That patient has a right atrial line, an aortic cannula, and a right superior pulmonary vein line, so you wide into the venous line. So you definitely have look at the right atrium. The right atrium is flaccid, but yet look at the right ventricle. It looks stuffed, but it's not stuffed. Do you think that looks like fluid overload? Next slide. Bonk. No, it's not. What that is both of those examples are an example of third spacing, because the harsh reality of it is you can have a patient that looked like that lady or a heart that looks like this, and your lines, your access lines or venous return lines are chattering because you are intravascularly hypovolemic. So if you remember the title of my slide, what is fluid overload? And my next slide was we should not use the term fluid overload because it is not specific enough to what you are trying to describe. Is the patient hypervolemic, or is the patient hypovolemic intravascularly? And is the patient third spaced, hypervolemic in the interstitial spaces or intracellular spaces, or are they not? So that's really, you have to increase specificity and be more accurate in our description. Next slide, please. the fact of the matter is that both of those patients can be grossly hypovolemic. Next. The venous capacitance system, our venous capacitance system is a giant reservoir. Although it acts much more significantly than just a reservoir, has a lot of function to it. But 60+% of all of our blood volume is in our venous capacitance system. Next. So this is a very interesting slide, and it's a concept that I want to sort of get everyone to understand, because where I go from here, a lot of this foundation is going to be very important. So you have a mean systemic pressure. Now, that's not to be confused with a CVP. It's not to be confused with an arterial pressure or a mean arterial pressure. It is the mean systemic pressure. And how do you measure mean systemic pressure? Well, it is measured by stopping all circulation. If you stop all circulation, simply stop the heart, and this has been experimented on in the ICU with patients who were in the process of dying, where you have lines in various places within the vascular system, and the patient dies, and all circulation stops, and then you get a pressure. All of the pressures throughout all of the blood vessels will eventually equalize and become a pressure. And that pressure is between 10 and 12 millimeters of mercury. That if your patient, assuming your patient, is euvolemic at the time. If it's a trauma patient and they've died from massive bleeding, then it doesn't, the test doesn't work. They have to be a normovolemic individual. So our mean systemic pressure is for us, is about 10 to 12. That's what it is. So if you look at this diagram on the left, this is a baseline. And you'll see that you have unstressed and stressed. And again, this is the venous system. Above it, you see the LV, you see the arteries, you see the vascular waterfall, which is your capillary bed. So let's now look at the venules to the veins and all the way back to the heart, your venous capacitance system, which is the round cylinders. What does unstressed and stressed mean? Well, if you took a waterbed, and I tried to I was going to do a demonstration with a balloon, but it wasn't working out because I didn't get the right balloons, but that's a different story. If you take a waterbed that's completely empty, and you've set it up, and you were to measure the pressure, it's pretty much zero. There's no pressure in it. There's nothing in it, right?
No volume.
But you start pouring water in it, but it hasn't yet begun to expand. That pressure is still zero. And you keep filling it, and eventually it starts to take some sense of shape. So now you probably got some pressure. But you keep filling it and keep filling it until it has reached a point where it is the shape it's going to be. It has reached a point of where it now has tension on it. That is the point by which you go from unstressed to stressed, because if you fill it more from there, then you start to actually stretch the material. So that would be your stressed volume. Well, think of your venous system, excluding your right atrium, as the exact same way. That system has to be full enough to have a stress, you have to have a pressure in order for there to be venous return. The higher your mean systemic filling pressure is to a point, because it has a point, just like the Starling curve has a point, you have a point, but the higher that is, the higher your venous return is. And therefore, higher your cardiac output is. Up again to a certain point. You can obviously go then into heart failure, in which case the right atrium, pressure starts to go up. So your gradient between your mean systemic filling pressure and your right atrium is what the driver is to get venous blood through the venous system into your right atrium to fill it, beat, empty, fill it, beat, empty. That's the gradient that you need. So if you were to deplete your intravascular fluid volume to a hypovolemic state, you will have inadequate venous return vis-a-vis our patient is empty, and we see it on bypass all of the time. But that can also happen through vasodilatory processes. So if you have a patient, which you would look at on the right, that has a venous capacitance system that now has been dilated, you will see that because of that dilatation, it's going to take more volume to fill the unstressed portion because you've made a bigger waterbed. It's not a twin size. You've graduated to the queen, and you're going to need more volume. But what really the thing that's most important is that if you don't change your volume, then what happens is the stressed volume pressure, the volume within your stressed system decreases, lowers your venous return, lowers your cardiac output. Next slide, please. So in this particular example, you see the right atrial pressure, which is on your x-axis, and your venous return on your y-axis. So as you take in the blue lines, move your mean systemic filling pressure to the right, which also does increase your CVP, though they are independent of each other. It's important to understand that. You see that your venous return goes up. So on the left, the furthest to the left is hypovolemic, then you have euvolemic, then you have hypervolemic. And this can be demonstrated all of the time with a fluid challenge. Our patient looks kind of wimpy with their blood pressure, so give them a challenge of 500 and let's see what happens. You throw 500 cc's in, you see an immediate improvement, and although that may only be transient, we could talk about the reason for the transient nature of it is because the fluid all now went out into the interstitium or because some other reason we don't know. But nevertheless, we see it, we fill the heart, we come off bypass. What do? We start filling it. We're not just filling the heart, we're filling everything, but you know, volume challenges can tell you whether or not you're euvolemic, hypo, or hypervolemic. Next slide, please. Here we see the mean systemic filling pressure on the y-axis, blood volume on the x-axis, and the center green dot is our control. And what I'm showing here is as you give the blue triangles, as you give an alpha agent, you see that you are reducing now the size of the tank. You're going from a queen back to a twin, and so your tank size has decreased given the same volume. What happens? Your mean systemic filling pressure goes up, and over all spectrums of blood volume. So you can be hypovolemic, but still have a better blood pressure because what you're doing is making the tank smaller. You can increase your venous return given a particular blood volume simply by decreasing the size of the reservoir. And then the same would be the case, you know, for the opposite spectrum with the adrenergic blockers or vasodilators, which you see with the red dots. So below the control, but over a spectrum, they lower the blood pressure by lowering your mean systemic filling pressure. Let me see here. Check your email for. Oh, okay, good. With the right parameters turned on. I just got a message that with the right parameters, the Siemens 500 blood gas analyzer can do those calculations for the talk on DO2. So thank you very much. I appreciate that, Kevin. Okay, let's see if this is working yet. Next slide. Next slide, please. Edema and fluid overload can be mutually exclusive. Although hypervolemia is always associated with some edema, edema is not always associated with hypervolemia. Next slide, please. Data supporting hypervolemia as a prognosticator of bad outcomes. CPB is highly dilutional. Inconsistent treatment of albumin, I think, is the norm today, surprisingly. Cardioplegia dilution, depending on how much you give, and now with Del Nido, we give a lot of crystalloid, more crystalloid than I think we did when we gave when we used Pledgisol, frankly. And then arguments over pump, ultrafiltration on pump continue to seem to pervade. Next slide, please. Hypervolemia has been shown conclusively, and I want to say that one more time. Hypervolemia has been shown conclusively, not conjecturally, to be associated with a host of unfavorable outcomes, to include respiratory complications, neurocognitive problems, AKI and ARF. Again, AKI and ARF. This is hypervolemia, all right? Increased vent times, length of stay, increased cost, and increased 30-day mortality. And I put my references for that right there. Next slide, please. Here's a very interesting slide talking about fluid balance. Assessment of fluid balance status and fluid responsiveness in the middle. So you have your optimum or euvolemic patient right in the center on the scale. Volume depletion, so hypoperfusion results in hypotension, shock, organ hypoperfusion, and AKI from ischemic disease. And then if you over-aggressively fluid resuscitate, you have impaired oxygenation, edema, hypertension, organ congestion, and although the slide doesn't say it, all of those things we know leads to AKI, okay? So optimum fluid balance is very important. I'm not advocating for hypovolemia. I'm not advocating for hypervolemia. I'm really advocating, and I think, use of the hemoconcentrator to become normovolemic is what I'm trying to achieve. I think all of us are, those of us that use it. Next slide, please. Okay, so this is a very interesting slide. The organs, cerebral edema. This is the consequences of fluid overload. Impaired cognition, delirium. For the myocardium, conduction disturbances, impaired contrast. I wonder how much AFib we are contributing to due to myocardial edema post-operatively. Impaired contractility, diastolic dysfunction. The lungs, pulmonary edema. It results in impaired gas exchange. Reduced compliance, you got stiff lungs, increased work breathing, you can't get the patient extubated. Renal interstitial edema, reduced renal blood flow, increased interstitial pressure, reduced GFR, uremia, salt and water retention. That's the one with most problems. Hypervolemia, look at that list compared to the other. It hurts the kidneys more than anything else. Hepatic congestion, impaired synthetic function, and cholestasis, gut edema, malabsorption, you get an ileus, tissue edema, poor wound healing, wound infection, pressure ulcerations. So these are all of the consequences of fluid overload in the various organ systems. Next slide, please. So this is very important. I really need everybody to read this, so I'm going to read it to you as well. Most people think there are a lot of bad people running around the world. There aren't a lot of bad people. There are a lot of bad ideas. And bad ideas are worse than bad people because bad ideas are contagious. Bad ideas get good people to do horrible things. Please, I'm going to ask all of you. You're all good people. It's a bad idea to not use ultrafiltration on pump. I'm just going to say it. So don't be that person, okay? Let's try to follow this logic. Next slide, please. The patient, actual patient, I say patient one's the only patient, okay? 72-year-old, you like that?
It's a big study.
Yeah, it's a big study. 72-year-old female, poor nutrition and sedentary lifestyle, 5'4", 78 kilos, EF is 40%, patient has 3+ MR from a dilated LV, 4-vessel disease. She's in for a cabbage plus mitral valve repair or replace. Next slide. Here's her chemistries and albumin 138, 4.6K, 101, BUN creatinine look good. I mean, she's actually, this looks like she has reasonably decent renal function, normal creatinine certainly. Total protein is 4.6, albumin 2.8, so she is a little hypoproteinemic and hypoalbuminemic. And by the way, does everybody know, you may know this, I don't know if you know this, but an albumin level of 2 or less is an independent predictor of mortality. An independent indicator of mortality is an albumin level of 2 or below. And I've seen albumin levels of 1.2, and they look like that lady with the water balloons on her eyes. Okay, hemoglobin 32, or crit 32, HNase 32 and 10.3. Next slide, please. Total circulating volume is 46 liters in this lady based on the calculation. Circulating should be 5.4 liters, but she's got MR, she's got ischemic heart disease. I gave her an extra liter, 6.4 liters. Extracellularly, in the tissues, I bumped her up from 16 liters to 20 liters to accommodate for most patients I see with ischemic heart disease that have an ischemic 3+ MR for any length of time tend to have pitting edema. So I'm just, taking that as a liberty and an assumption, if you will. Next slide, please. Heart rate's 100. This is right on anesthesia, just post anesthesia induction. BP 138/90. PA is 56/32. Not unexpected. CVP is 18. Not unexpected. So, I mean, these are pretty. This is what we see frequently. These are not unusual, really weird, unusual, bizarre numbers. But this patient is in some element of failure. Doesn't mean she's hypervolemic. Just means she's in failure. Because you can have this presentation, interestingly enough, and you can have a very low mean systemic filling pressure at the same time. That's why using an echo to look to see if the patient is euvolemic or what their volume status is, let's say, or right atrial pressure, or SVC collapse, or any of these other things, actually is not, it's okay, and that's a whole nother talk for another day. It's okay, but it ain't great. It's not really that perfect, but it's what we got. Next slide, please. Anesthesia volume for the pump, before pump they gave 800. Our priming volume was 1,300. We wrapped 500. Even though I don't wrap, I don't believe in it. I think it's a bad idea. Again, bad idea. Bad ideas are, what that leads to. Good people doing really bad things. Urine output was 200. Cell saver was 100. Del Nido dose was 1,000. So taking everything we added up and subtracted, our total volume for the pump contribution to the patient's circulating volume is 2,900. The on-pump reservoir volume is now 3,400 cc's. That's what you got in the tank, okay? And you're flowing along, get good flow, everything looks good. Turn next slide. So how much is the patient now fluid positive? Okay, well, we really don't know, and we assume a lot because of the things that I just discussed. The CVP is 0, so we know the heart's empty. We've got plenty of flow, plus all the added volume is down in the reservoir or refilling the venous capacitance system and restoring the PMS, or is it instead third spacing? We don't know the answer to that either. Next slide. Predicted crit is now 22, so I basically took the red cell volume, divided it by the now new total blood volume, and got them what would be the predicted hematocrit. We don't know what the COP is because we don't measure it. We didn't run an albumin or anything on pump, which we probably need to. But do we know where the volume is? What is the PMSF? What is the vascular tone? What is the status of volume in the interstitium? Again, we really just don't know. There are ways to know, but it takes work and it takes changing how we do things. Next slide, please. And it's not really that hard. So final thoughts. If you are not flowing enough in this patient to provide the required DO2 because of cannula size, circuit limitations, you're flowing what you think is enough, but you thought would be enough, it should be enough, but isn't enough for whatever reason, and you're not flowing enough at this moment in time. Let's assume that. And there's nothing mechanically wrong. The patient has 3,400 cc's in your reservoir. You can't flow anymore because you overflow your cannula, but it's just not enough, okay? That's the scenario. You have a normal SVR, okay, so you have normal vascular tone. You've corrected your COP to have a normal plasma refill rate. Now you've given albumin to try to deal with that. It was in your prime, let's say. The patient is not making much in the way of urine at that moment. You have 3.8 liters of volume in your reservoir, and you remove 2.8 liters of that with ultrafiltration. Again, from an open reservoir, we use an open system. Even a bag is kind of an open system. It's not truly an open system, but it's still an open system because it's a displaceable reservoir, right? And you raise your crit from 22 to 28, increasing your O2 content per vols percent. Therefore, your flow being the same, you're now delivering more oxygen to the tissue under that scenario, and you still have a liter of volume in the tank, okay, plenty of flow. Tell me how we're causing AKI. That's my question. My question for anybody. Anybody that can answer that question for me and calls in will get John's houseboat. Doesn't matter who it is. Call in, you'll get it. You'll get cups, you'll get something. I'm telling you, you will get something. You'll get a free trip out here. You'll get a free, if you can convince me that anything that I just discussed or described causes AKI, help me understand that. I'll wear a man bun for the entirety of the next show. I'll do whatever you want me to do. I don't care.
You don't have any hair.
No, but I'm going to get a stick-on man bun. They have them. I'll get one. So, next slide, please. Redneck murders are hard to solve. There are no dental records, and all the DNA is the same. Okay, any questions? You don't have to stay focused on that slide. You can change. Oh, do we have Keith here? I see Keith in the background. Keith, where are you? Hey, Keith.
Hey, guys. Good morning.
Hey.
I don't know those two new panelists, but hi, John, and
That's
I'm glad
Tammy.
to.
Tammy, and that's Min Tran. Tammy Sparacino and Min Tran. And y'all, that's Keith Smolik. You know Keith from Global Blood Resources. He's the hemo bad guy.
Hemo bad guy.
Yes, Tammy knew you.
Not personally.
All right, Tammy. Thank you. So, anyways, yeah, great talk. I can't deny anything that you've said. I think it is so important that a lot of people don't pay attention is that every single thing an anesthesiologist does to you tends to dilate you. And what are anesthesiologists taught? Volume, volume, volume.
Mm-hmm.
Instead of trying to get that SVR back to normal, they're all taught to challenge the Starling. So give volume test, volume test, volume test. But we all know that it all floats back out third space, So the key is to have a normal SVR and a good colloid osmotic pressure. So you're drawing that fluid back in on the venual side. So, hydrostatically on the arterial side, it's pushing it out, delivering all the nutrients and oxygen and all those good things. But on the venual side, if you don't have a good colloid osmotic pressure, it's not going to go anywhere unless it's pulled back in. Now, normally, you and I and everybody sitting around here, we have a system called lymphatics, the body's natural sewer system. But that's paralyzed because it only works with skeletal muscle movements. Everybody's paralyzed on a table. So until they get that tube out of their mouth, their lymphatics is essentially paralyzed. So it really boils down to good SVR and good colloid osmotic pressure. If you have those two things, you can help regulate that volume a lot better. Third spacing that fluid a lot less.
Very good point. Very good points.
Yeah, I was telling Joe, I guess it was last night, we were talking about the way I've always learned about it and the way I've always read about it, and what I believe is that the instant we go on bypass, you automatically have several strikes against you when it comes to third spacing for several reasons. One, you just brought up a very good point. Your lymph system, which takes your interstitial fluid and naturally returns it slowly back into your venous system, is really not working very well, if at all, because you're paralyzed. Number two, not fully understood, but a non-pulsatile flow automatically tends towards third spacing. So if you do go on bypass and you've added things to your prime to where you're just isoosmotic, you're still going to third space because of those two reasons. The non-pulsatile flow allows for more vascular permeability, and your lymphatic system is not returning the natural fluid that it would normally bring back. So it almost tends you to think we should be a little bit hyperosmotic on bypass just to keep from third spacing.
You don't want to cause that demyelination syndrome.
So here's an interesting thing. When I went to work at my first job, they were having their routine patient was 10 to 15 pounds overweight in the ICU. And we did have a lot of volume, a lot of cardioplegia volume. I was very aggressive with the hemoconcentrator, and I was only there about 6 weeks, new kid out of school. And one of the surgeons came up to me, "What are you doing to my patient?" I'm like, "Oh, geez, now what have I done?" "What are you doing to my patient?" I'm thinking, "What have I done now?" He says, "My patients are only 2 to 3 pounds overweight." I've never seen that before. We've always had patients here 10 to 15 pounds overweight. I said, "Well, I'm just removing a lot of that volume on pump." So it was actually a very good thing. But let me ask you this. Have you ever had a patient come off of bypass who weighed less than when he started? I've never heard of that.
No, probably not.
Right.
I
So
don't believe so.
even all of our efforts, prime with albumin, mannitol, maybe some people do the hemoconcentrator. Maybe I've seen people prime with Lasix. I don't know of anybody that's ever had a patient weighed less in the ICU than they did in the OR. So even over all these efforts, they still third space. They still third space. So you have
That's a very good point.
you're at war with this third spacing, the way I look at it. So, it automatically wants to happen, and we have to try to reverse that, because the third spacing, it's not just going into the feet and the hands, it's going into all your organs too, and this is going to decrease your time in the ICU is going to be increased, extubation time's longer, your cardiac function on inotropes is going to be longer, your ICU stays are going to be longer, and the patients that I did this with, all were discharged a lot quicker from the ICU because their functions were better.
I agree, and I think a lot of people also underappreciate how significant interstitial edema is at reducing microcirculatory blood flow. So as you continue to third space, you start creating essentially a global, if you will, parenchymal, the organ itself's compartment syndrome, where you are increasing the pressure on the microcirculatory system, making it very difficult to flow through it. What are your guys' thoughts on ultrafiltration, volume statuses? What's your experience been? What do you think, and what has your experience been in terms of managing these things with the other clinicians you have to work with?
I agree. Like, as soon as you go on bypass, the patient, gets all these inflammatory responses. You have all this increased permeability and all those spaces, and patient gets fluid overload. So you definitely have to stay ahead and, try to get that, oncotic pressure up and, give albumin and, replace it. I think that's why I'm an advocate of wrapping, because the less hemodilution I can hit the patient with, then I think that's going to save the patient from losing red cells and losing diluting that albumin and proteins.
You're not a bad person.
Well, let me just interject
It's a
something.
bad idea.
Joe, let me just
But the patient still, I'm not taking the volume away from the patient. I'm just reducing the fluid that I'm giving to the patient because the blood is still going to go back into the patient as soon as I go on bypass. I'm just taking a much
Borrowing it.
Well,
borrowing
so
it for a few seconds.
So think about this for a second. If you're a person who loves low prime volume, we all do. If you're a person who likes wrapping, you should be the biggest fan there is of hemoconcentration because it does both of those things. And it removes inflammatories, which wrapping doesn't do.
Of
Well,
course.
but
So,
don't you
I
think
mean-
a combination of ultrafiltration
Right,
and
right.
wrapping
Absolutely.
needs
I
to be
mean-
done together?
No. She's tricking you.
No,
She's tricking
So
you. Think
if-
about what she just
if
said.
you-
don't believe in wrapping, do you?
Well, I think you should do it to a small extent because, listen, for 25 years of millions of dollars of research went into, can we make this arterial line filter 25 cc smaller? Can we make this oxygenator 50 cc's less of prime? Can we squeeze some out of the heat, from the heat exchanger side? Everybody was focused on lower primes, lower primes, lower primes. Here's a technique doesn't cost a dime to do, and you can decrease your prime by 300, 400, 500 cc's, and it takes no expense whatsoever. Didn't take hundreds of millions of dollars of research to invent a new device. We just do it. So, I think you should do it. It's there waiting for you to do. But why are you doing that? What he just said, Min, is correct. You're not going to dilute the patient. You're keeping your osmotic pressures up. You're not diluting your hematocrit. So hemoconcentrator does all those things, and it removes inflammatory. So you should probably wrap to some extent. Now, you're opposed to people wrapping when it starts to cause ST elevation or ST depression.
Well,
That's
no,
really
not-
your biggest
no,
concern.
I think if you have to treat the patient with neo, if you have to
Right,
treat
right.
the patient to give them a blood pressure because you are making them so hypovolemic while you do this, then I believe that the risk-benefit ratio is imbalanced to too high of a risk. And especially when I see them going backwards through the arterial line, retrograde through the arterial line, again, I think although maybe only a small risk, but air entrapment into the arterial line or some other incident occurring while you're doing that, to me, is not worth. I just don't think it's worth the risk because what do we wrap? 500 cc's, 600 cc's. I can go on bypass, and while I'm going on ultrafiltrate out 500 cc's, before the blood makes it down the venous line all the way and back up to the end of the arterial line.
If you have
So-
vacuum on it.
Huh?
If you have vacuum on that.
Yeah, of course. I always put vacuum, but I always put vacuum on mine.
Oh, okay. Not a lot of people do that.
That's how I ultrafiltrate. I turned it on the Neptune at max back. Okay, I get serious about this.
Yeah.
So Keith, what's your thoughts? I'm
Okay.
anti-wrap. They're pro-wrap. I think just ultrafiltrate it off as rapidly as you can, and the almost momentary at best 500 cc in out is inconsequential. Plus, I think you're kind of doing a flush, but go ahead.
Okay, so I am a proponent of RAP and VAP. What I've seen or what I was taught back many 15 years ago was to do it very, very slowly through your stopcock, connected to the cell saver. So basically, you had a line going off of your manifold that went to the cell saver, and you could control how much with the stopcock, how much fluid was coming down, how much fluid was going forward. And we used the arterial filter as like the promontory pass. So we would take a little bit of venous blood, and then we would shuttle it all the way out through the arterial filter to the cell saver. And then once we got to the arterial filter, we stopped. And we moved the clamps, and then we did arterial back to the arterial filter. And essentially the entire circuit, I'm not lying, essentially the entire circuit was primed with the patient. Now, do you need to give some neo? Unfortunately, yes. Sometimes an anesthesiologist needs to play ball with you and give a little tiny bit of neo in order to keep that pressure up.
Well,
But what happened?
It's more than just a little teeny bit of neo, number one. And number two, here you're telling me that you're taking a patient, so you're accepting hypoperfusion for however long this takes you to do this versus a transient period of time of getting a 1,000 cc's. Maybe you could wrap just the venous side, but I mean you're going all out here, and for what? I'm sorry, I didn't mean to interrupt you, but go ahead.
Okay, so like
I'm
I
gonna
said,
convince you otherwise.
Well, I'm open to everything, as you know. So the deal is, I told you before, anesthesia does not play with the SV. They let it dilate out. So they've got a patient they think is okay, but really it's 800, 900, 1,000. It's not 1,300 where it should be. Okay, so they do need to tighten the patient up a little bit because everything that they've done is dilated the patient, including giving them a lot of fluid. There are two papers, one that I sent you by your cell phone, which is really important. And then, of course, there's the classic one, the Chappelle article on fluid balance. Pop that up real quick here. Chappelle's paper, it says, A Rational Approach to Perioperative Fluid Management. This guy wrote this paper back in 2008. It is still the gold standard of fluid management for anesthesia and surgery. The other paper that I sent you, which is really important, it just came out in the fall, is... early negative fluid balance is associated with lower mortality after cardiac surgery.
Yeah, there you go.
And that was again that was in JEC, or no, it was in Perfusion. And basically, their conclusion was this observational study indicates that a negative fluid balance is associated with lower postoperative morbidity and mortality in critically ill patients in cardiac surgery.
Yeah.
Bingo. I mean, it doesn't get any better than that. So again, this 2 days of talks that you guys have been doing on fluid balance, everybody needs to clue in, again, having a good collar osmotic pressure and a good SVR. If you get those two things, you're not going to lose so much fluid third space. You won't give so much fluid. You won't get into the spiral where you need to give blood products and everything else. And then, of course, the absolute easiest things to follow patients is weight change, and how much chest tube drainage.
I know we've gotten
those are
from that.
They cost. How much do those things cost? They're free.
Yeah.
So I've got two people that are doing studies right now, and that's some of their observances. Is how much weight did they put on, and how much chest tube drainage. Again, cost nothing. Those are just observational things. The goal obviously is not to give people hemodilution is the enemy. Some people say, oh well, we dilute these people out. We what is that, ANH? So
Yes.
they take fluid off the patient so that they can have it at the end of the case.
Yeah.
Oh, the platelets aren't beat up. Well, guess what? About 60 to 80% of those platelets are still functional in the pump blood at the end of the case.
Yes.
So why would you think that the blood you drew off earlier than that was going to be any better?
And the blood that you put in the bag has lost probably an equal amount of them just by being in the bag.
Yep, and even though they rock it for a couple of hours, and this again, I don't want to poo-poo it because there are people that swear by it, but I still say that if you do all the other things, and again, it's not one thing, it's everything,
It's not one thing,
multidisciplinary,
it's multiple.
multimodality,
Right.
and that's what works. I always said it was easy. We would treat a lady who was 60 kilos, Jehovah's Witness in the morning for an AVR, and her crit was, let's say it was 35, coming in the room, but we never gave her blood products, not at all. But in the afternoon, we had another 60-year-old woman, or a 60-kilo woman, and her crit was 37, but somehow she got blood. We just didn't pay attention as much. We didn't watch like a child, how people hover and everybody watches each other. You want to treat every single patient like they were a Jehovah's Witness with a small BSA. And if you can do that, you can avoid giving blood products to almost everyone.
I think that's a very good point. I think that those are all very good points. Okay. I think we're up. Can we take a 5-minute break
nice.
and then we'll get you teed up? Just a 5-minute break, though. We're not going to be gone long. So, David, we'll go to 5 minutes. We'll see y'all back in 5 minutes, okay?
Thank you.
Thanks, Hey, Keith, thank you.
Yep. You're very welcome. You guys are doing a great job.
Thank you. We
We're not talking
appreciate that
about
from you very
wrapping
much.
What he was talking. Yeah, it's not.
Okay, you guys have a good day. I'm going back to the farm.
You too. Come have a
cutting
break
your
with us. We're doing a
lines and
crafish
all of these
boil.
things. You don't have
Okay,
to wrap so
thanks.
much that you have
See you
to
guys.
necessarily
Bye.
video support.
Right.
ready.
Hey, we're live. Okay, welcome back, everybody. Min will be right back after he finishes his cup of coffee. We're going to jump right into John's next talk, how ECMO contributes to maintaining kidney dysfunction and casually participates in the development of AKI. And I hope you're also going to talk about how we can attenuate that, since we do a whole lot of ECMO, and I know you do too. All right, moving on. Next. John,
Okay, thank
floor
you.
is yours.
Thank you so much. Thank you, Joe. So let's see if our slide clicker is going to work.
Over here.
And it is not working.
Let me see.
So
I
let's try.
told you this thing's not working.
It's not working.
Next slide, please.
Okay, so so anybody out there listening, this is going to be a pretty involved lecture. It's quite extensive. I'll try to go through it and make sense of it. But one of the big references, and when I use a reference very heavily in a talk, I want to leave it up front and let you know up front that this was one of the big review articles that I used on this lecture, in addition to other references. But this one really was a real complete, comprehensive review of what I wanted to talk about. So Dr. Villa and Dr. Katz on this topic did an article in 2015 on cardiorenal medicine, and they did a real good review, comprehensive review. Go ahead, next slide. So what is the incidence of AKI and renal replacement therapy on ECMO? Just to give you some idea of what we're talking about. This was a paper in 2010, European Journal of Cardiothoracic Surgery by Dr. Jan and his colleagues, acute kidney injury in adult post-cardiotomy patients with ECMO. And they evaluated using the rifle classification and Aiken. Next slide, please. So they took 67 adults aged 37 to 63 post-cardiac surgery who received ECMO. Next. And their results, the incidence of AKI during the first 48 hours of ECMO was 83%. Next slide. The in-hospital mortality rate, the renal replacement therapy patients had a 73%, and the non-renal replacement therapy patients had 32%. Next, please. So here's an article by Dr. Keilstein and his colleagues, 2013, Nephrology, Dialysis, and Transplant. They did an article called Renal Function and Survival in Patients Undergoing ECMO. Next. They took 200 patients, adult, age 17 to 83. All patients received ECMO. Next slide. The results, 60% of the patients received renal replacement therapy, 40% did not receive renal replacement therapy. The 90-day mortality rate on the renal replacement therapy was 83%. The 90-day mortality rate with patients that did not require RRT was 47%. Next, please. So renal injury, this is a paradoxic progression. Next. I got line by line. So AKI in patients on ECMO is mainly due to the hemodynamic deficiency, first of all, associated with the baseline disease. In other words, if your patient is on ECMO, he obviously had some type of hemodynamic deficiency, hypoxic state, that brought him to coming on ECMO in the first place. Next. So now, the now vulnerable kidney is then exposed to a considerable stressor, i.e. the ECMO circuit. Next. So while ECMO effectively supports organ function, it also contributes to maintaining the kidney's dysfunction through several mechanisms. Next. So the aim is to understand the mechanisms responsible for maintaining acute kidney injury in ECMO patients. Next. And to identify their physiological pathways. Next slide. So the factors derived from ECMO therapy that cause or maintain AKI. Next slide. We have three things. We have, first of all, we have the patient-related factors. These are things that the patient already came with before we put him on ECMO. Next slide. The second one is those things that occurred on ECMO, and those ECMO-related factors. And then the next slide shows the cannulation and access-related factors. All three of these we're going to look at individually and all the different things under each one that are factors that either maintain or cause AKI and related to ECMO. Next, please. So now let's look under patient-related factors. This is pre-ECMO occurrences. Next. So we, so the patient history. A patient comes to us with certain risk factors. Okay. Next, you can kind of go through these: renal failure, diabetes mellitus, if they have that, hypertension. These are all risk factors. Infection, anything with a elevated white blood cell count, COPD, left ventricular failure, all again leading to hypoxic states, possibly poor delivery of oxygen, peripheral vascular disease, if they're a smoker, if they have hyperlipidemia, and then finally, if most of our patients at some point in time received contrast either in the cath lab or during a CT scan, actually, all of these things, contrasts have an increase, a pretty significant increased rate of AKI. Next, please. So hypoxia due to the baseline disease, i.e. the reason for ECMO. It's a cardiac or respiratory failure, but it results in some type of tissue hypoxia, which is the reason why they came on ECMO. So next slide. So now, also, pre-ECMO, what about the various pharmaceuticals that they receive? And there's so many of these are actually nephrotoxins. So we have NSAIDs and ACE inhibitors. Next slide. And those alter your renal autoregulation. And unfortunately, they alter it to the downside because they disrupt your renal autoregulation. We talked a lot about that yesterday. And it actually ends up being a detriment. So ACE inhibitors, people who take NSAIDs, some of us do that on a normal course of regulating our own blood pressure and so on. It does alter your renal autoregulation. Next, is it working? No. Okay. Diuretics and antiviral drugs. Many of these cause swelling and inflammation of the kidney. Next, vasopressors almost universally reduce renal blood flow because they vasoconstrict the afferent arteriole, which is the arteriole that leads directly into the glomerulus of the nephron. Then you have a lot of your antivirals, antibacterials, drugs, zoledronic acid, and your contrast, as I mentioned before. All of these, in some way or another, are nephrotoxic. Okay, and there's many more than what we could list on this slide, but this gives you a good overview of what the patient could have been on or exposed to even before we put them on ECMO. Next slide, please. So now we have the ECMO-related factors, those things that are maintaining or causing AKI while we're on ECMO. Hemodynamic factors, go ahead. Under that, you have delivery of oxygen, pulsatile flow, which is really, when we're on ECMO, we're going to talk about this, we have a mix of the native pulsatile flow of the patient and the non-pulsatile pump flow. Then we have reperfusion injury, because remember, the patient was ischemic, hypoxic, which led him to become on ECMO. So we almost always have some type of reperfusion injury, and a lot of times it's on a global scale, right? Next. So then we have, in addition to hemodynamic factors, we have our hormonal factors. And that would be our renin-angiotensin system. We're going to talk about that. Atrial natriuretic peptides. And we also have then finally a big one, of course, the inflammatory response. So these are the general things we're going to talk about, ECMO-related factors contributing to AKI. Next slide. So let's look at the hemodynamic factors real quick. Delivery of oxygen. DO2, the formula, as you know, is blood flow times the oxygen content of the blood. What does that break down to? Blood flow being Q, the formula there, 1.36 times hemoglobin times saturation, plus a small factor with the PO2. So any factors which alter the DO2, which is blood flow, hemoglobin, arterial saturation, and partial pressure of oxygen, will have a direct impact on the delivery of oxygen to the tissues and will contribute most likely to AKI. There's a lot of studies done on delivery of oxygen and AKI. So just to give you some idea, somebody was asking earlier about what should the hemoglobin be. Well, if you're anemic and it's hurting your delivery of oxygen level, you're going to have a propensity to AKI. Any low flow state, vasopressors almost always constrict. in the worst possible place when it comes to the kidneys. Any low cardiac output syndrome. Go ahead. Hypoxic state, emboli, hypovolemia, hypotension. Just to give you some, there's a long list of these. But anything that detrimentally affects the delivery of oxygen. Go ahead. So now let's look at what I call the interplay of the native pulsatile flow and the non-pulsatile pump flow of the ECMO. The significance of pulsatile flow in renal perfusion is well documented. However, it's a little bit poorly understood. But here's a paper by Dr. Ashkenazi, who did one in Clinical Journal of American Society of Nephrology 2012, and also Dr. Nemoto down in Annals of Thoracic Surgery in 2003, and their conclusions were very similar. In hemodynamically stable patients requiring VV ECMO, where the patient's pulsatile flow is still native, the native pulsatile cardiac output maintained minimal negative deleterious effects on renal function. Next one. So, next slide, interplay of native and pulsatile flow. Many studies have demonstrated there is a benefit of pulsatile flow to the kidneys and a reduction of AKI, but we don't really fully understand why that is. When you compare cardiopulmonary bypass to ECMO, in ECMO we often have the advantage of providing a shared circulation, as I said, patient's native heart combined with the ECMO pump. But so due to this interplay between the pulsatile native heart and the ECMO pump, we can often have the benefit of some amount of pulsatile flow, and this does tend to reduce our AKI. So you can see there where the red arrow is that we don't have the perfect pulsatile flow because we have a patient who we're supporting non-pulsatile, and they also are contributing to some pulsatile flow. But even this amount has shown to be a little bit of a benefit in reducing AKI. Next one. So let's look at reperfusion injury following the ischemic event that led them to become on ECMO. Now, I just put this as right in the middle of the center of the slide. Reperfusion injury is the most major cause of AKI. We talk about this a lot, right? Reperfusion injury, what is reperfusion injury? Reperfusion injury is caused when the blood supply returns to the tissue after a period of ischemia or anoxia. Now that sounds like the perfect thing. If you're ischemic, let's fix the problem and return a good blood supply. But it's paradoxic. It's a paradoxic tissue response by the ischemic tissues following the restoration of blood flow and tissue oxygenation, whereby the restoration of the circulation results in oxidative damage and subsequent inflammation. So it's the excess production of a reactive oxygen species that is the critical factor in the genesis of reperfusion injury. So the dominant cellular and enzymatic sources of excess reactive oxygen species are, to give you some idea, xanthine oxidase, and this is an enzyme that catalyzes the oxidation reaction which forms uric acid, and in doing so generates reactive oxygen species, O2 free radicals. But in reperfusion injury, it produces these free radicals which cause tissue injury. Next. Now we have something called NADPH oxidase, NOx also called. What this is, go ahead. It's activated NADPH oxidase generates a superoxide during an immune response. And then we have the mitochondria. This mitochondrial functions in the initiation and development of inflammation. A lot of people don't realize that. Next one, and we also have nitric oxide synthase. This is catalyzes nitrous oxide, which is then a pro-inflammatory mediator that induces inflammation. So go ahead. So reperfusion injury following an ischemic event, what is the pathophysiology of this? Reperfusion of ischemic tissues first results in microvascular injury. So the injured endothelial cells produce more reactive oxygen species, resulting in an inflammatory response. This is largely what's responsible for the reperfusion injury. This then leads to a permeability of capillaries and diffusion of fluid across the tissues, resulting in swelling, i.e. third spacing. Now the white blood cells then respond to the tissue damage. This then releases a whole host of inflammatory factors, interleukins, free radicals, cytokines, macrophages, platelet activation, complement activation. The white blood cells then bind to the endothelium, obstructing small capillaries, leading to more ischemia. Okay? Now, what happens on ECMO? Healthy tissues, first of all, normally contain free radical scavengers because we have O2 reactive oxidative species normally in our system, but our tissues contain these radical scavengers normally, and this prevents tissue damage from these oxidizing species. But once there's been a systemic hypoxic event that led to the ECMO, the ischemic tissue now has a decreased function of these protective O2 scavengers. So then when the adequate circulation returns, brings in this oxygen-free radicals that normally wouldn't damage the tissue, but that does now damage the ischemic tissue because the protective function of the endothelium is now greatly diminished. This is why it happens. The restored blood flow reintroduces oxygen within the cells that now damages cellular proteins, DNA, and the plasma membrane. Damage to the cell's membrane causes the release of more free radicals, and since there's been a global systemic hypoxic event, the effect is usually widespread. Okay, so this is why it's such a large inflammatory response. So this results in a massive inflammatory response, which then incites interleukins. These are cytokines that upregulate the immune response and inflammation. Then you have oxygen-free radicals. These are toxic byproducts of oxygen metabolism that damage cells and tissues. You then have cytokines. This is a broad term, by the way, for a large number of proteins and peptides that mediate immunity and inflammation. Macrophages, what are those? Those are white blood cells that engulf other cells, foreign substances, cellular debris, microbes, even cancer cells, actually anything that is not indicative of health. Platelets, those are thrombocytes whose function normally is to initiate coagulation by enlarging and adhering together. Those are activated. And then finally you have the complement system. Complement is a part of your immune system that enhances the immune system's ability to clear foreign microbes and promotes phagocytosis. So all of this is going on in the inflammatory response, and we're going to look at all these a little bit more closely also. So next slide. Okay, so now we're going to look at the renin, angiotensin, aldosterone system. We're going to look at how it normally functions, then we're going to look at what happens on ECMO. So what is RAS? It's angiotensinogen, converts to angiotensin 1, angiotensin 2, and finally aldosterone. So it's a bit of a cascade, 3 or 4 steps. So angiotensinogen is naturally produced by the liver, and it's freely circulating normally in our blood. But renin is released by the kidneys in response to a low blood pressure. This gets the process started. Renin converts angiotensinogen to angiotensin 1. Then the cascade continues. Angiotensin 1 is now in the system, and as it passes through the pulmonary beds, which is where ACE, angiotensin conversion enzyme, resides, ACE converts angiotensin 1 into angiotensin 2. Now we're getting somewhere because angiotensin 2, go ahead, then angiotensin 2 now has been created. Angiotensin 2 is really where the rubber hits the road because this is where we get start having things occur differently because it stimulates the adrenal gland to secrete aldosterone. Aldosterone is a strong antidiuretic. Okay, so this is how we get to aldosterone. So now, looking at it graphically to understand it a little bit easier, angiotensinogen normally released by the liver. It's circulating in our blood at all times. Then, in response to a drop in blood pressure, the kidneys immediately secrete renin. Renin then converts angiotensinogen into angiotensin 1. Angiotensin 1 is in the bloodstream, comes through the lung tissue, comes in contact with ACE, angioconversion enzyme, which then makes angiotensin 2. Angiotensin 2 gets converted. Now angiotensin 2 has 2 very powerful functions. First of all, it's a direct arterial vasoconstrictor. Number 2, it directly influences the adrenal glands to secrete aldosterone. Next slide. Angiotensin 2 is what you really want to focus on when we're talking about this, because it's a vasoconstrictor and secretion of aldosterone, which is antidiuretic. Next slide. If it's an antidiuretic, it decreases urine output, which increases blood volume, and those two things put together cause an increased blood pressure. So the kidneys accomplished what it set out to do. It sensed a drop in blood pressure, and it caused this cascade to produce angiotensin II. So just stopping for a minute, everybody's heard of ACE inhibitors as an antihypertensive. Well, if you see there, if you don't have ACE, you can't produce angiotensin II. You can't vasoconstrict. So this is why it's a antihypertensive. Okay, next slide. But what occurs during bypass? We're going to talk about bypass real quick. We're also talk about ECMO. What are the effects of ACE? There was an article that was published, Dr. Gorin and his associates. This goes back into the 80s.
Here, I just got it.
What do you got?
Where you're going?
Oh, okay. So now, they looked at the fact that when you went on bypass, after the lung was isolated, meaning it's no longer in the system, ACE levels fell rapidly. Well, the ACE is living inside the lung tissue. So if the blood isn't circulating through the lungs, so after 20 minutes of bypass, they said there was a 33% drop in the baseline values of circulating ACE. Within 10 minutes of restoration of lung perfusion, the ACE rose back all the way up to 90% of baseline values. So what happens on ECMO, though? Okay, there's a decrease in blood pressure, may prompt and will prompt the kidneys to release the renin, right? The kidneys want that blood pressure to come back up. However, renin and ACE may be greatly reduced or blocked altogether. We're going to talk about why, resulting in severe vasodilation, lower blood pressure, poor renal perfusion. All of this is a possible cause of AKI. So the kidney wants the blood pressure to come up, but let's see why on ECMO it may not be able to. So, but on ECMO, how might the renin or ACE be limited or blocked altogether? So what we have is a decrease in blood pressure is going to prompt the kidneys to release renin, but they may not be capable because of the acute kidney injury. They're not functioning normally. Okay? They may want to release renin, but they may not be capable of it. In VA ECMO in particular, think about it, a large portion of the blood bypasses the lungs. We're essentially on perfusion, right? Central cannulation VA, a large portion of the blood is not going through the lungs anymore. This is going to limit your conversion of angiotensin I into the angiotensin II that's going to cause you to vasoconstrict. In patients with ARDS, the injured lungs can't produce as much ACE. They're injured. They're not functioning normally. Less angiotensin II gets produced. Other conditions such as sepsis where endotoxinemia actually can deactivate ACE. So this results in much less ACE being utilized or produced, results in severe decrease in blood pressure and decreased renal perfusion. This is what can happen on VA ECMO. So looking at it from the graph again, you have the normal angiotensinogen secreted by the liver. Kidneys sense a drop in blood pressure, it secretes renin. The renin is going to convert angiotensin I. Angiotensin I is going to come through the lungs and hopefully get converted into angiotensin II. But what happens on ECMO? In certain ECMO settings, the kidneys aren't able to, because they're injured, secrete the right amount of renin, or any. If you are on, if you have acute lung injury, the lungs aren't secreting ACE. If you're bypassing the lungs because you're on VA ECMO, you're getting very little ACE. So look, the angiotensin II, very little is being produced. If that happens, you don't have vasoconstriction, you actually might have vasodilatation. So if you have a drop in blood pressure, you may not even be able to increase it through this method.
Well, this is a perfect, I think, description of vasoplegia.
Could be.
One of
them, right.
There may be another reason, but you know, we've seen patients that were vasoplegic that we couldn't get the blood pressure up no matter what we did. No, go ahead, I'm sorry.
So if you don't have angiotensin II, which is a vasoconstrictor, see, you always have certain levels of all of these circulating in your system. It's not all or nothing. You have a modest amount that's keeping our homeostasis. When you have something that wipes it out below normal, it has the opposite effect. So if you wipe out your angiotensin II, you're going to end up being dropping your vasoconstrictor. You're actually being vasodilate, which is what your opposite wanted to do. It also can't stimulate the adrenal gland to stimulate aldosterone. So now aldosterone, which is an antidiuretic, if you take the aldosterone out, you have a diuretic effect. This increases the urine output, which also drops blood volume. Those two things put together are going to further drop your blood pressure, which was your problem in the first place, which is why kidneys secreted renin. You had too low of a blood pressure. Now, go to the next slide. It can cause AKI. So now we're on ECMO. You're asking how does ECMO help or contribute or maintain AKI? Because your renin angiotensin system is either blocked or incapacitated, you can't naturally bring your own blood pressure up. Why are people on so much rocket fuel? Trying to get the blood pressure up. because the normal hemostasis of the system is not able to function properly. Kidney injury, lung injury, not able to produce the normal angiotensin system. Okay, next. Let's talk about, Joe, I know you love this topic and you asked me to talk about this. And this is something I think perfusionists forget about. I have forgotten about this in my career. Atrial natriuretic peptide. Let's talk about what happens with this and what it is. ANP is secreted by the cardiac muscles of the atria. 80% of it's in the atria. We have some in the ventricles, but let's focus on the atria. These cells contain stretch receptors which respond to increased atrial blood volume. That's their job. You have an overdistension, and they're going to be responding to that. So ANP, atrial natriuretic peptide, it also directly innervates the kidneys. Doesn't have to go through a cascade process. It sends signals directly to the kidneys. The main function of ANP is to cause a reduction in intravascular volume by increasing urine output and causing vasodilatation. Okay? Now, so ANP acts directly on the kidney to increase urine output in 3 ways. Let's look how it does it. It directly dilates the afferent arteriole, increasing blood flow through the glomerulus, therefore increases GFR. It also has an effect on the permeability of the glomerular tubules. Not only does it increase GFR, it's increasing their permeability as well. That's the effect of ANP, which really increases in urine output. Okay? Then it inhibits the renin secretion system. If it does that, you have an inhibited production of angiotensin II, which then, instead of being a vasoconstrictor, your angiotensin II levels drop, wear off, you end up in vasodilatation. Again, remember, the ANP is responding to an overdistension. It thinks there's too much blood volume on board. So it's going to work to decrease the production of aldosterone, which then increases urine output, i.e. decreasing the volume overload that it thinks is going on. Then,
but at the same time, constricting or dilating the afferent arteriole so that you get more renal blood flow for that same blood pressure.
Right. Okay, so go back one. So now we're going to talk, go back one. Oh, you know, actually you went forward. Okay, keep going. Yeah, forward. So now, but what happens on ECMO or bypass? Because remember, we're cannulating normally, right? Cannulate at the right atrium on bypass. So what is happening with this? Because this is a system that responds to an overdistension of volume for the most part. Since atrial distension is the stimulus for ANP release, ANP release depends on the distension of the atria at any given moment. It's going to fire or not fire, right? So either you're going to have ANP secretion due to an elevated atrial filling pressure, which could be elevated blood volume, or could be right heart failure, or you're going to have ANP is very greatly reduced due to a low atrial filling pressure, or in the case of bypass, maybe even a negative atrial filling pressure, because you got the cannula there, right? So this will be either low blood volume or venous cannula drainage issue, right? So due to any number of factors in ECMO or cannulation volume management, you could have atrial distension, you could have atrial negative pressures on a cannulation or anything that's going on at any given moment. And this can change moment to moment on bypass, right? Or on ECMO. So go to the next one. So now, this is what we're looking at. If there's an elevated blood volume in the right heart, an elevated blood volume in the right atrium due to right heart failure or volume, there's an atrial distension and substantial ANP release because it wants to decrease. So dilation in the arterial, afferent arteriole, Joe, increased GFR, increased the permeability, it also has that effect, decreases aldosterone production, decreases angiotensin II production, which then, both of those increase urine output, which means decreased blood volume, and then finally vasodilatation. So if you have an overdistended right atrium, the ANP says, this is what we need to do, lower our volume, vasodilate, I don't need to be distended. I'm overfull, right? Okay, now, if there's low blood volume or negative venous drainage pressures, where now we're getting to, for example, on bypass, there's atrial relaxation and no ANP release at all. What happens there? Constriction of the afferent arteriole. That's decreased perfusion of the kidney. When you go on bypass and the natural atrial nephrotic sensors are used to a CVP of positive something, 5, 8, 10, you've now went negative, you have complete cessation of all your ANP being released. The kidneys think the blood pressure is 0. Sends a signal to the afferent arteriole, vasoconstrict. You drop your glomerular blood flow. You decrease your GFR. You decrease the permeability. You wonder why your urine output's low on bypass? And people are struggling to get the urine output up? The atrium is telling them right now, we have no volume. Don't not release anything. Okay, so increased aldosterone production. Aldosterone is an antidiuretic. What happens? Decreased urine output, increased blood volume, then vasoconstriction. All right? This right here, now highlighted in pink there, purple, it's the afferent vasoconstriction and the vasoconstriction by angiotensin II that can cause acute kidney injury while on perfusion, while on ECMO. Due to your cannulation and your volume status in your atrium. So let's look at hormonal factors. Systemic inflammation, that's the Sears response, right? This is a big one, big one. Go ahead. What is the Sears response? Systemic inflammatory response syndrome. It's a consequence of a dysregulated or hyperinflammatory response. It can be due to an infection, like in sepsis, or it can be due to a non-infectious insult, as in ECMO, right? Sears universally occurs during ECMO and is associated with organ dysfunction and considerable mortality. What is this response? It's recognized. Now, this is how people wonder, well, how do I know I have it? What is it? How can I recognize it? This is what you have. If you have 2 or more of the following of these things, temperature has risen to 38.5, or, believe it or not, it can actually become hypothermic. If you become, for unexplained reasons, below 36 degrees or above 38.5, that's one factor, and your heart rate is above 90 beats per minute, go ahead, or your respiratory rate is 20 breaths per minute or faster, and your white blood cell count is 12. If you have any 2 of these or more, this is from a Sears response, okay? You can also, next slide, go into what's called Sears shock. If you have a blood pressure drop on top of it, that's 40 millimeters of mercury or more. So this is what the Sears response will do. Usually you have more than 2 of these going on. Okay, so, but what happens on ECMO and bypass? The blood is exposed to the extrapleural circuit, results in a general term called blood shear stress. Okay? Blood shear stress causes 2 major things to happen. First, it's going to cause coagulopathies. Second, it's going to cause SIRS, systemic inflammatory response. This is global. This is not maybe on some patients. All patients experience this. The SIRS response is neutrophil storm, it's cytokine storm, it's oxygen-free radicals, and it's complement activation. On the coagulopathy side, we have activation of platelets, we have activation of coagulation factors, and we have thromboxane A4 release, which is further stimulation of platelets, and this results in hypercoagulation, fibrinolysis, and microvascular thrombi. Okay? That's on the coagulopathy side. Let's look at the systemic inflammation side. Because what is a neutrophil? Notice a neutrophil storm. Mass neutrophil migration, thromboxane, and prostaglandins. Hyperinduction of autoamplifying of cytokine production. Oxygen-free radicals, they attack lipids, amino acids, your DNA, your RNA, and your lysosomes. And the complement is a protein cascade promoting cytokines, phagocytes, membrane attack complex. So you want to know why the Sears response is so massive and so important, and why you might want to reduce that by removing some of these things, which we were talking about earlier in hemoconcentrator. Look at all the things that are happening when we put somebody on bypass or an ECMO. Okay? Go ahead, next slide. So this results in a massive inflammatory response which incites renal tissue damage and AKI. What was the topic of this lecture? How does ECMO contribute to AKI? Because all of these things are happening. Your interleukins, your free radicals, cytokines, macrophages, platelets, and complement. Massive inflammatory response. Now let's talk about how cannulation and access-related factors can contribute to maintaining AKI. So we can have distal limb ischemia due to cannulation placement in the femoral artery, right? This ischemia is going to start reperfusion injury. All the damages of ischemia are going to send signals of inflammatory response to the kidneys. Compartmental syndrome can develop, right? Again, liver ischemia, reperfusion injury. Something called hypermyoglobinemia. This is a breakdown of your muscles where the myoglobin ends up becoming in the blood. Very tissue nephrotoxic.
Yeah.
Right. If you have a femoral cannulation and you've had an aortic dissection, guess what's going to happen to your renal perfusion, renal ischemia? These are all cannula access issues. You can have thrombosis, air embolism. I mean, we've seen many times thrombosis around the cannulas, right? So one more thing I think is up there. Yep. So you can have negative pressure and hemolysis resulting in hemoglobinuria. You know? So if you have we see this all the time with ECMO where your line is chattering.
Yes.
We live with that all the time. Or if you have the cardio help and your negative pressures are alarming. And people sort of, after a while, if you do enough of these, you just kind of get used to it. But I never get used to it.
It's alarm fatigue.
Because what happens is, and I want people to think about this too on bypass, not just on ECMO. When you have a line that's chattering, I thought this was obvious, but apparently maybe not that obvious. The walls of the atrium, the walls of the IVC and the SVC are slamming up against the cannula. Mm-hmm. What do you think that's doing to the endothelium? It's a single layer, one cell layer. You're damaging your endothelium, right? Now you have damaged endothelium. That's what's preventing your blood from clotting against your intravasculature. Mm-hmm. That's your endothelial layer. So if you have high negative pressures that's causing this chattering, try to reduce it and try to at least minimize it. You know what I mean? Mm-hmm. We all live with it to some extent.
I don't. I mean, I don't think we do. We don't in our practice. We are going to figure out what's going on.
Do you really?
Yeah, mm-hmm. we'll turn the RPMs down. We'll make adjustments. We won't live with that. No.
So all of these things can or will lead to AKI, just a whole nother aspect of ECMO, or could be perfusion. That is one reason why it contributes or can maintain AKI. Go to the next. Let's see what we got here. So in conclusion, ECMO is an effective support therapy for patients for reversible cardiac respiratory therapy or bridge to transplant durable VAD. But it's clear that RRT, renal replacement therapy, is almost always required, provides fluid managed overload, and is beneficial in removal of inflammatory mediators. AKI is frequently observed in ECMO patients and is related to several conditions derived from the ECMO therapy. They're mainly hemodynamic, hormonal, and inflammatory in nature. So the severe condition of the patient and the many variables of this complex treatment usually do not allow us to exactly identify the pathophysiological mechanism responsible for the AKI. We have people that are on ECMO and we have AKI, but as you saw from the slide, can we really be sure where it came from? Did it come from the vasoconstriction? Did it come from the toxins? Did it come from a decrease of oxygen flow?
Did it come from poor cannulation?
Yeah. Did it come from before? Most likely probably did. So paradoxically, exactly what you just said, the various pathophysiologic pathways responsible for the development of AKI during ECMO are the same ones which produce the pathological conditions requiring the ECMO.
I got it again.
There you go, you got it, huh?
2 times in one day.
I think that's my last slide. I think I have the references up here. So again, a lot of this came from Dr. Villa and Katz's article, and I believe there's you continue with the slide for a second, I think there's 45 references from my talk here that are referenced either in my talk or in that article that they reference.
Very good.
So there you go.
Excellent job. Very good. I didn't get applause. How come I didn't get an applause?
Yeah, you should have got some applause.
I did.
We should applause for you.
I didn't get any. I got none. So let's talk about the inflammatory response because you've talked about that so much during this time. You've got Crohn's disease, ulcerative colitis, asthma, psoriasis, eczema, and they give those patients biologics. You look at all of that disease, those disease processes, and what are all those diseases caused from?
Well, it sounds like they're all inflammatory.
They're all inflammatory.
Yeah, they are.
They all involve an invasion of white cells somewhere, leukocytes somewhere. And so attenuating it is in actually controlling that. The most recent, thing with asthma and eosinophil invasion or high level of them in the lung, and that's what it blocks. So, we see this all the time, but for some reason, it's we see it being treated for these various diseases, but in the acute setting, it's really not that. Now, I don't think it's just that well understood, but we used to have Zygris. Does anybody ever remember Zygris? Do you ever remember that? That was supposed to attenuate for septic shock and for systemic inflammatory response syndrome, SIRS, using that, but it failed miserably. They stopped, but it was to block the massive infusion or invasion rather of white leukocytes into the various endothelial layers and cause that global ischemia that you would see from essentially that, like pulmonary problems and so forth and so on. So, and that's what it was for, was to block that leukocyte invasion into the cellular walls. But it didn't work.
That would have been great.
I wonder how much, I wonder how much aprotenin actually did benefit in that result with kallikrein inhibiting units, that it had. And how much of that medication actually did cause AKI, now that we look at this, retrospectively, and how we're better understanding AKI now, and it was always funny to me because the guy from Duke, I think his name was Dr. Smith, I had gone to a lecture that he was doing where Bayer was paying him to give a lecture on the benefits of trastuzumab or aprotenin, and at the same exact time he gave that talk, his paper, along with the other Duke representatives, was being published, denouncing aprotenin as a cause of acute kidney injury, so causing renal failure. So I thought that was always somewhat of a contradiction for him, but I guess money talks. That's the way it is.
Yeah, I mean, I think that if you look at least one of the progresses in the last 20 years is the biocoded circuits. Why did we do that?
Yes.
Why did we do that? Why did that come along? Because we were trying to
Reduce it.
make the surface more compatible.
Right.
We're going to be, I don't know if you know this, but back in the 80s, NASA here in Houston looked at, under a microscope, in very elaborate electron microscopes, the layer of the endothelium. And they said there will never be a surface as smooth as the endothelial layer. We'll never be able to manufacture one.
That's amazing. I
Within
know.
the same universe of the smooth, it's a single cell layer. And that's what I was saying. If you damage the endothelium, it doesn't take much. It's only one cell layer. But it's such a single cell layer, like side by side, that they'll never be able to create a surface as smooth as that. Because they were looking into it. For some reason, they're always into material development.
Well, yeah, I
And
mean, if
NASA's
you
into
can-
huge material
yeah, I mean-
development.
I
And
mean,
they looked at the endothelial level and said,
Well,
we'll never be able to come close
I mean,
to the smoothness of it. But it does many more things than being smooth.
I remember
It's releasing
of course, it
all
does
kinds
a
of,
lot.
many things.
But
yeah.
I remember having a discussion with somebody back in the 80s, like you're talking about, in mid-80s and late 80s, talking about how until we can figure out how to create an endothelial layer in these mechanical hearts, thrombosis was going to continue to be a problem. And but that's not you can trick it. And I think that's been the goal, the direction we've gone, because I don't think it is creatable. The goal is to try and trick but our biology is so complex that we treat it over here, but do we really treat it over? We don't. It's very hard to replace nature. Very, very, very difficult.
Right. That's really the point. Yeah.
Very difficult.
We have to figure out ways to trick it, or at least satisfy most of what we're trying to do. But
Well, I think what we try to do is we try to get through blocks of time. We don't need something unless it's a total artificial heart, but for forever.
Right.
Most of what we're dealing with is transient.
right, that's true. Yeah.
Thoughts on
Until something
all
else
of this,
comes up.
Min?
I mean, that was a great talk on AKI and just touching bases on the relation with the lungs and the angiotensin.
The
and
organ
the renin.
crosstalk you're talking about.
Yeah,
Yeah,
that
so
was
this one is with
this
the
one.
ACE inhibitors.
with
right?
ACE
Yeah.
inhibitors. And
Oh, yeah.
the release of renin and all that. I mean, it just you
Well,
forget,
a light
you
bulb
forget
went
about
off in my head.
You forget
I
about all
didn't
those
ever
things.
think of it.
Yeah, you forget
I
about,
saw that I could anticipate where he was
and
going.
it's just a
okay.
cycle
Oh, did
because
you? Oh, okay, I see what you're saying.
Yeah, that's
know.
why I got it. I was like, I got it, before you said it.
Yeah, that's one of the more powerful systems in our hemodynamic system to regulate fluid balance and blood pressure at the same time, because they're usually related. And
Yeah.
the kidney's smart, just release renin, we're going to vasodilate or vasoconstrict, and we're going to conserve urine or diurese, because and both of those will work, not just one thing. And if it can't do that, if it's blocked or incapable of doing it, or the lungs are taken out of the system, and so no ACE, the ACE doesn't get in contact with the blood, you actually might have more of what it's trying to prevent occur. You know what I mean? So you ever notice, like I was saying before, how many drips some of these people are on?
Yeah,
And
massive.
You get the evolving
3 or
cycle
4
of
or
like
5
kidney
of them.
injury.
Yeah.
Vasodilation, then you're treating the dilation with pressures, and then that's harming the kidneys even
Right,
more.
Yeah.
right. We're really in a bad paradox with, and then if you go back to, kidney gets injured, now it's sending all these signals, organ crosstalk, to damage other organs. So how many times do we have multi-organ? How many times you only see one organ failure? Almost never, right? We have, how many times
Oh,
do you
very
see single?
rare.
Oh yeah,
Very
and
rare.
so you had one organ get insulted, but why are now we on this downward domino effect where other healthy organs were healthy are now becoming more devastating? So it's way beyond what I think our understanding and our ability to control it is. We just live with it,
I
and
agree,
try
yeah.
to work around it. I think
Exactly.
for the
We
most
try to
part.
get we try to get through an event. Try to get through surgery. We try to get through their lung issue. Before try to give their lungs the rest they need, or their cardiovascular system, as the case may be, VVVA, and get through that event before we have caused any more damage to these other organs. And I think that's why when we see early recovery, generally speaking, and we can wean, we're better off. When we see them not recovering and having to be on it very long term, notwithstanding, younger patients do tend to do better in those circumstances and be on the Centromag, biventricular Centromag for a year before they go on. But no one at 79 years old is going to get a biventricular Centromag. They're going to be turned down because of age. They're going to have, they're going to be it's not going to happen. And maybe even I don't really know what the age cutoff is for that. But, if they're a renal failure patient, they're not going to be a candidate for transplant. They're not going to be a candidate for, unless they're getting a kidney transplant. But if they have, serious comorbidities, it goes back to what I had mentioned earlier, my earlier thought, that young people are very durable and they can tolerate a lot.
Yeah,
Well,
that's
they
what
can
it is.
withstand the injury or
Yeah.
insult.
And they can, right. Now, there's always the curveball that gets thrown at me where I'm like, is this lady ain't gonna make it. And then the next thing you know, somebody calls me and says she's sitting up complaining about the hospital food. I'm like, ooh, really?
Those are called winners.
Yeah.
And they're a little bit few and far between, but we have a joke around the ECMO unit. We need a winner.
Yeah.
We'll say we need to win one.
Yeah.
Yep. And that's because it's so tough. I begin to see my opinion a little bit is you see these patients that are on for weeks at a time. Forget about months, but just take 4, 5, 6 weeks, and then they have GI bleed out of nowhere, seemingly. Then they get through that, and then they have, they have a little bit of a brain bleed. They get over that. Then they, it's like, where, it almost makes you believe that the Sears response is just every few days or so waiting to get another one, and it's, where is this coming from? I mean, then they get septic for a while, then they don't get septic, and then also they get septic again, and that keeps happening, and then you start thinking, well, that's residing in the circuit, a whole separate issue now, and all of these things, the whole ECMO thing for periods of time is just really wrought with devastating complications waiting to happen. They may not all happen, and maybe we'll get through them, and maybe we won't, and hopefully we come out the other end. And I don't think you know. I mean, you just have to keep at it until
I know.
either you DC them or God DCs them. It's one way or another is going to probably happen.
Yeah, and I think
Hopefully.
that's the issue. Again, if you're, we got to want to keep harping on the issue. You're 21 years old, and you're having all of those, morbidities coming up. All these complications keep happening. Anyone would be extremely reluctant, short of having, documented, diagnosed brain death, wanting to stop. But where is the limit of our resources for the 68-year-old, morbidly obese, smoker, drinker, not controlling their diabetes, non-compliant patient that we now are on day 13, 14 on ECMO with no real signs of improvement, but no further deterioration except for some, minor things. Where do you just wait until nature takes its course, which we know is probably likely? Should that decision have been made sooner? Do we start saying, if you meet these criteria, you get this much time to turn it around, but statistically we know that you're probably not going to? And then who makes that decision? And then how do we all live with ourselves when, we know, and it's happened to me where was convinced I was leaving that day and that lady was not going to be with us the next day. You remember, you know what I'm talking about. And a week later, she was sitting up, and she was 70. She was above 75 years old, and that gave me a lot of pause, man. I was like, ooh, I'm not predicting anymore. I quit predicting. I'm not going to the horse track. So, and you've seen that.
Yes, I have.
But we've also seen where it's obvious.
Right.
Oh, yeah.
I wanted to circle back a little bit to the inflammatory response and your experience, especially since you've traveled a lot, with the use of RRT, and why aren't we doing that all the time? If we know all the benefits that it has, why are we waiting until we are seeing a failing kidney to implement that with ECMO?
Well, in our particular hospital, they get it almost right away. About 80–85% of the people, they get it almost right away.
So you have it as a standard of care. You
Just-
get
just
ECMO and
about.
you get that.
You better have really healthy kidneys. Otherwise, you're probably going to get some form of, even if it's not.
But even if you have really healthy,
24/7?
even if you
Yeah,
have really
well.
healthy kidneys, all the inflammatory things that are going on. If you had healthy kidneys, you're now doing so much damage to them, which
Right.
you've now shown
Right.
is going to do damage to all other sorts
You're
of
absolutely-
organs.
you're
That is an
absolutely right.
excellent point,
You're absolutely
Tammy.
right. You're
Very
absolutely
good
right.
point.
And
And
you may actually have just touched on something that is, if you were to put together some type of study or incentivize other people to do that, 5 years from now, we would look back and say, we should have been putting everybody on RT. Why weren't we doing that? And we
Right.
do that now. If you're old as me and Joe, we look back on the 80s and 90s, and believe me, today feels like the 80s and 90s. We thought we were doing everything we knew was right. When you've lived long enough, you look back and go, why were we doing that? Why were we doing this? We thought we were doing right. That's going to happen again and again and again and again. So what you
I
just
think
touched
this is
on,
going to be a major point
yeah,
that we
what you
look
just
at.
touched on, I think, is brilliant, because we're learning that the kidneys. You talk about young people tolerating stuff. The kidneys are not able to. I mean, there is some conditioning, like you said, they're adaptive, but most of what we're doing is so sudden, so abrupt. The damage happens, and we're in a big downward spiral that we hope we can get out of, and sometimes we do, and I would say most of the time we don't. At some level, we don't get out of it.
I agree. Let me say to your point about we used to think we knew what we were doing. I want to say that, and then I want to address your issue about the continuous. I'm going to say CRRT versus RRT, because I do think there's a very strong distinction. We have to be very careful. I
It's
think.
just generalizing.
Yes,
Right,
but I like to say CRRT because I do think in these kinds of patients you're talking about, intermittent, the kidney works. How often are the kidneys working?
They're working all the time.
All the time, 24/7. They don't stop. So I think in a chronic dialysis patient, it makes sense. They've adapted. They go to the clinic. They get cleared. For the acute patient, it doesn't make sense. It
Because
has
their
to be
kidneys aren't used to that insult, and they have no idea what to do with it when they have the therapy and then they don't have the therapy.
Right.
Right.
So I think having continuous therapy just makes more sense. Otherwise, you have the typical peak and trough of whether it be metabolites or it's uremia, or it's whatever the issue may be, electrolytes, acid base balance, and so forth. I can't think of what I was trying to say, but nitrogenic.
All your nitrogen waste products, yeah.
That's what I was trying
Yeah.
to say. Thank you. But I did a case in 19, I believe it was 1980. It was in 1980. And I remember the guy's first name. I used to remember his last name too. His name was Ricky something. I can't remember his last name. And he had been shot. And he had multiple fistulas between his aorta and his vena cava. And they needed to go in there and repair all of these. So we were going to do deep hypothermia with intermittent circulatory arrest in order to be able to fix these holes. And so we went on pump and I cooled way down. And while I was cooling, I believe, because I was taught to believe this, that you are increasing the viscosity of the blood, which we are when you're cooling, but you have to correct that, not thinking I'm already diluting them. And I would take off 500 cc's and give 500 cc's of Ringer's lactate or whatever we had, and then kept doing that. And I had this poor kid's hemoglobin, I think, down to 5 or 4 or 5 by the time I got to my circulatory arrest temperature. And then we warmed it back up again, and as I was warming, and he was diuresing, and he diuresed dramatically, like he had diabetes insipidus. I'd give that blood back and got it all back in him. But when I look back at that retrospectively, I don't think I did any harm per se. I could have, but I didn't do any harm because he was 21 years old. I think that was a really dumb thing to do. I wouldn't do that today. I wouldn't let the hematocrit get down that low, 14, 15, whatever it was. I'd probably not go under 21.
I'll give you a lot simpler one. How many people have not seen the simple Sarnes heater cooler? What does it have on the heating knob?
Yeah.
30,
Yeah,
38,
32.
40, and
Yeah,
42.
42, that's right.
Yeah.
A million times plus, everybody, time to rewarm, right over to 42.
Yes.
We find out now, after millions and millions of patients that have done on rewarming the water bath and rewarming the arterial blood, because we used to warm to a bladder temperature of 37 before we came off. You know what you have to do to get a bladder temperature of 37?
You have to be at 38.5.
You have
You
to be
have
at
to be
38.5
at like
or
your
so.
Minimum.
brain temperature is probably 38.5, 39. And we thought that was great. Why? We used to bring, if we didn't do that, we'd bring the patient to the ICU. The patient's temperature plummets. The nurse for
degrees.
the next 24 hours is going crazy because she's having to manage arrhythmias possibly and trying to warm the patient and putting heaters on everything and warming any blood she has to give, and it's a coagulopathy. So we were like, why are we doing this to our poor ICU nurses, giving them a cold patient? Let's bring them to them warm, like where they're supposed to be. So we warm people up. How many decades of that did we do?
A lot.
Many decades of that.
A lot.
Nobody saw there was
I
anything
was
wrong with it.
still doing that 15 years ago, dude.
Yeah.
Well, even when I graduated, it's not that long ago, 17 years ago, from Texas Heart, that was a novel idea. I remember hearing a presentation about the relationship, just in general, to the damage it was doing to the brain and the arterial oxygenator temperature, not going above 38, just from that perspective. And I remember hearing that talk, and a lot of people in the audience, doctors included, this is not true. We need to warm the patient. So it's a new idea.
And
Isn't that amazing?
I say
Yeah.
that because your thought about putting people, even if they don't have poor kidney function, the benefit of removing, you saw the slide. I mean, how elaborate, you could,
You remove all
there's
of it.
so much stuff going on with the Sears response. And it keeps growing like a tree. And I probably could have grown 10 more branches, taking each one of those out. What does that mean, cytokine storm? That's hundreds of other things. What does that mean, neutrophil storm? That's hundreds of other things. What is the oxygen-free radical storm? That tree could have grown all the way out to your backyard over here. So if you're able to take something and reduce this Sears response, whatever it is, I don't know if it's, could be hopefully come out with many other things. You're not going to, one of the biggest things happens is a kidney injury. And so if we just say, well, these guys' kidney's fine, let's not take any, maybe we're making a big mistake. I think we probably one day will find that out.
Possibly.
I bet
Yeah.
that's a good possibility.
Well, with that said, I'll say this, that it's humbling to be around you really smart people. And I think that, you know, I learned from these courses that we keep doing, really the biggest lesson for me is how little I actually do know.
Yeah.
And it's a little bit on the frightening side, but I'm hoping that us and our audience, people that we watch this show tomorrow, the next day, or whatever it may be, learn something, and that we take that just one thing and make these very simple incremental steps that make sense, if it makes sense to you, and add it to our practices so that we can improve patient outcomes, even if it's just by a fraction. And at least we're moving in the right direction as we continue to evolve and learn and better understand these interrelationships between the various organs, the cardiopulmonary bypass circuit, the ECMO circuit, CRRT, plasma adsorption therapies, all of these things that we've been talking about for the past several weeks. And so that's what I think. What are your final thoughts?
Well, I'll give you one more because it's really kind of a thorn in my claw. And we're going to look back on this.
I think it's a thorn in your side.
Thorn in my claw in my thorn. Yeah, that does
Yeah.
make sense. I think we look back on this too. Think about it, Min and Tammy and Joe. How many times have you said or walked up to an ECMO patient, or we're getting ready to do an ECMO, and we're deciding on what circuit to use, and we'll say, well, let's use this because it's coded. Let's use the cardio help because it's biocoded. And then you realize, oh wait, it is all except the cannulas. What do you mean all except the cannulas? Now we've just negated a big benefit of what we just. So, and we're living with this every day, all day, every day. People say, we don't have to be, heparinized because and I say, all except the cannulas. So this is like running a marathon, right? And you get 100 yards before the finish line. I'm going to stop here. I'm not, and you haven't accomplished anything because you stopped short of the finish line. So, you talk about, demonizing one product or another. Why don't we get on the manufacturers to say, why are you giving us cannulas that are uncoated? You have the technology. You're doing it with your other products. Why are we, you know what I'm saying? So if you look back at this 10 years ago, you think to myself, why did we accept that? Why did we accept that we can accept just the cannulas? Because every time we had, not every time, but if you flow below 2 liters on your ECMO circuit, you begin to get worried that if you're not giving heparin, why?
Yeah.
Why?
You get
Because
real
you might
anxious.
clot off. Where is the number one place you clot off? At the cannulas. How
Yep.
primitive is this idea? But we're living with it every
I've
day.
seen it happen many times.
Yeah.
People put the cannulas in,
So
they don't have the
wh-
heparin in.
why are we-
and next
why
thing
do we
you know,
accept
you
this?
can't flow
You can't
because
flow
it's
'cause there's-
clotted.
yeah,
Why do
you're
we
not getting
accept
any
this? It's
drainage.
absolutely right in front of our face. It's as obvious as you can imagine, but we live with it every day like it's fine. It's a simple fix, right? Coat the cannulas.
Tell the manufacturers. Coat the
I
cannulas.
understand one manufacturer does. Is it Medtronic or somebody now?
I don't
has
know.
heparin has biocoated.
I don't know.
Yeah, somebody does. I just heard it the other day. They have biocoated.
I'm not sure.
not
But
sure
you
about that.
you have the Protect Duo, the Crescent, all these different ones
Yeah,
come
maybe
out.
the Crescent. Yeah, I
And,
don't know. I don't know.
I
but
don't-
I
Yeah, I
don't
don't
know.
I thought I heard the other day
The
that
Crescent?
Medtronic
The
has-
Crescent?
Well, the Crescent's the new Medtronic, right?
Right.
Yeah.
Right.
I don't
Somebody
know.
said Medtronic has biocoated cannulas. I don't know that much about
That's
it. But,
Yeah, I don't know.
That's a great idea, though. That's
but
a
it's
great
kind
thought.
of silly when you look
It
back at
is.
it, right?
Right. One thing's coded, but they're
We've had the technology
I
for
think that-
over 20-something years.
I think we could have this same final thought to any of it. It's not just part of the picture. You have to look at the whole picture. So just your point, it's not just the circuit cannulas, for example. It's not just, CRRT is for the kidneys. It's for the whole body, you know?
Exactly.
right.
No, I think
Exactly.
that's how it should be looked at.
Yeah,
That's a very good
All
point.
the organs, yeah.
Were those your final thoughts?
my final thought.
Min, your final thought for the day?
I think everyone should, pay attention to what we talked about today and all the talks we've had, and I think there's a lot of little things that we could absolutely implement into, making, every case better and making decisions on how we can take care of the kidneys, because at the end of the day, if you don't take care of the kidneys, then it's going to be a revolving cycle of inflammatory responses, hypoxic, incidences, and things that we could do to improve the patient.
Very, very good thoughts. Very good thoughts.
Yeah,
Well,
that's
can I
exactly
have a final thought to the final thought? I think we're ready to cook some crawfish. I wish y'all could be here, but we are going to really enjoy them, and a bunch of our studio audience is also going to enjoy them. I'm getting clapped now because we're ending it. Okay. Don't forget next month, the New Orleans Conference online edition. Make sure you get the notifications. Please do the Facebook, Twitter, and YouTube thing, all the stuff you need to do with it, and we'll get you those notifications. But that's going to be a rocking and rolling great conference online, okay? And so with that said, I'll say happy Memorial Day to everybody. Okay, salute my brothers. And everybody be safe, enjoy yourselves, and let's go have fun for the rest of the weekend.